gentlemen, esteemed guests, and distinguished members of the medical community, it is with great pleasure and honor that I, Dr. Trishla Chaturvedi,
And I, Dr. Archita,
stand before you today as we gather to commemorate the second annual foundation of Dr. V.B Bhatnagar Memorial, Subharti Institute of Cancer Management and Research, hosted by Chhatrapati Shivaji, Subharti University, Meerut. Welcome to Subharti Cancer Update 2024. As we embark on this momentous occasion, let us first pay our respect to the divine with the Saraswati Vandana, invoking the blessing for wisdom and knowledge to guide us in the endeavors.
One, two, one, two, three, start. Om Hari Om. Om Hari Om. Shanno Mitra Shanvaruna Shanno Bhavat Varyama Shanna Indra Bahaswati Shanno Vishnu Brahma Namo Brahmane Namaste Vayu Tvameva Pratyaksham Brahmasi Tvameva Pratyaksham Brahma Vadishyami Ritam Vadishyami Satyam Vadishyami Tammamavatu Tadvattaramavatu Avatu Mamavatu Vattaram Om Namo Namaha Namo Namaha Namo Namaha. Jagad परम पाविनी वाणी कला रूपिणी वीणा वाणी जगन्मोहिनी सा पनि म पनि मनि सरे पनि सरे सरे म सरे म पनि म पनि सा पनि सरे सा पनि म पनि मनि सरे सरे म पनि रे म पनि सा म पनि सरे सा पनि म पनि मनि सरे सा पनि म पनि मनि सरे सा पनि म पनि मनि सरे म पनि सा नागेश्वराय के नागलोक प्रभापुरी के नागेश्वराय के नागलोक प्रभापुरी के राग मनोराज के गानलीन श्रुति समय दीक्षिते वाणी कला रूपिणी वीणा वाणी जगन्मोहिनी वीणा वाणी जगन्मोहिनी वीणा वाणी जगन्
जयति जय शारदा जय 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 जयति जय शारदा
Thank you so much. That was very beautiful. In the spirit of enlightenment, we will proceed with the traditional lamp lighting ceremony, symbolizing the illumination of knowledge and hope in the fight against cancer. I would like to request Dr. Dinesh sir, Dr. G.K. Rath sir, Dr. Sunil Kumar Saini sir, Dr. Chintamani sir, Dr. G.K. Thaplayal sir, Dr. H.S. Minas sir, and Dr. Satyam Khare sir to kindly come on the stage for the lamp lighting ceremony. Before we delve into the heart of our program, let us take a moment to acknowledge and felicitate our distinguished guests. We are graced and bestowed upon with the presence of our chief guest, Dr. Dinesh Pendharkar sir, Director and Head Medical Oncology, Hemato-Oncology and Bone Marrow Transplantation, Sarvodaya Cancer Institute, Faridabad. Dr. Dinesh Pendharkar stands as a beacon of innovation and leadership in the field of oncology, with a career adorned by remarkable milestones of contributions. As a distinguished fellow of FASCO, he has been an instrumental in pioneering the establishment of medical oncology as a specialty in India. His visionary approach led to the groundbreaking first bone marrow transplantation in the rural setup in 1998, setting a precedent for accessible cancer care. Dr. Dinesh's impact transcends borders, as evidenced by his globally recognized research on chemotherapy-induced toxicity, particularly his transformative work on hand-foot syndrome management using urea-containing ointment. His leadership extends to the professional empowerment and service in global oncology, exemplified by his establishment of the internationally acclaimed healthcare delivery model, bringing cancer care to over 150 districts in India. An esteemed program director, Dr. Dinesh has spearheaded numerous initiatives, including pioneering cancer control for primary care course in Bhopal, India, and MCMC course in Yerevan, Armenia, both supported by ASCO. His commitment to education is further underscored by his roles in organizing courses such as molecular oncology in New Delhi and acclaimed Best of ASCO series in Hyderabad. In addition to his exemplary clinical and academic endeavors, Dr. Dinesh has also played pivotal role within ASCO, serving as a past chair of the International Affairs Committee and Working Committee for the Multidisciplinary Cancer Management course. His dedication to advancing the field is further evidenced by his membership in various ASCO committees, including the International Affairs Committee and the IDEA Working Group. Dr. Dinesh's tireless pursuits of excellence, coupled with his profound impact on cancer care, epitomizes the essence of transformative leadership in oncology. I now request Dr. G.K. Thaplyal sir, Vice Chancellor of Subharti Meerut University, Dr. Anurag Srivastava sir, Director Oncology, and Dr. Kishore Singh sir, Head of Radiation Oncology, to kindly felicitate our chief guest, Dr. Dinesh Pendharkar sir. Thank you, sir. With a glimpse of his work, I would like to request Dr. Dinesh Pendharkar sir to please address the audience with his pearls of wisdom and motivation.
Good afternoon. It's really my honor and proud privilege to be here with all of you this university. I had a glimpse of the department and the facilities. It's really amazing. The best part, what I could found here was there is a vision and there is a mission. So the department is really trying to make and acquire best of technology, and I'm sure with time they would definitely deliver the best of treatment to the population. This is really a very thick populated area. It really requires many more efforts. But as I see, this university has got a campus of multiple other colleges. I think this is the right place for the advancement of cancer care, science and research. Only my humble request would be, we have to plug in research projects. I'm quite sure they are there in biology, physics, chemistry, but the need of the day in cancer care today is biotechnology. So we have to focus on biotechnology. The oncology is moving towards cells, towards DNA, towards RNA. So if we have a good biotechnology department, I think it will be possible to create something like CAR T cells or gene therapy. Believe it, they are all off-patent technologies, and it is not difficult to duplicate them if there is a zeal by the university. I know few labs in Delhi and in India who are working on this for last 10 years. They have a technology with them, they have this breakthrough with them. You must have seen CAR T introduced recently by one company. Another 2 products have been approved, and I assure you within next 6 months to 1 year, there are another 3 products to be approved. It's really going away very fast. In America, it's even faster. 20,000 patients literally were using adoptive immunotherapy in last 1 year. In this country, we can actually count them only on the fingers. Why? Because we are late in taking the technology, but we are not, it's not impossible for us to get the technology. If universities like yours really collaborate and come forward, there is a funding available, there is government funding available, and I'm sure with the vision and the mission this university has, you will be able to accomplish much more and offer to us as cancer specialists. I really wish you all the best. Thank you.
Thank you, sir, for such wonderful words and instilling an enthusiasm in all of us by your kind words.
It is my extreme pleasure in welcoming our guest, Dr. G.K. Rath sir, who have taken out time to grace the occasion. Dr. Rath is a former director, NCI, AIIMS Jhajjar, Haryana. Sir is an internationally acclaimed, renowned and pioneer in radiation oncology. Sir has had an excellent career and won innumerable prestigious awards and fellowships along with over 250 plus publications. Dr. Rath sir's achievement cannot be defined in one introduction. I would request sir to please share some thoughts and enlighten us.
Dignitaries present here and ladies and gentlemen. For me, coming to this institute is like homecoming because I have been involved with the cancer department practically from -1. So it's very gratifying to see. I attended the first one also, the second one also I am attending. Why this is important now? Not only for us, for the country. Let me tell you, cancer is a disease which since 2019, it's a publication by Lancet Oncology, 3rd of September 2019 for our students. The death from cancer all over the world has crossed that of cardiac. It's a 5-continent, 25-country study. So we have no other escape but to deal with it. Very, very important. So today, anywhere you go, you will find that we are struggling with the total management of cancer. Whether it is surgical, medical, radiation, imaging, pathology, or preventive oncology and palliative care. All are very important. In this country, we have 15 lakh new cancer cases in a year. Unfortunately, 8 lakhs die. And we teach our students a formula of 80-20. 20% cancers in this country only come early, out of which 80% are curable. 80% of cancers in our country come late, out of which only 20% are cured. That means 80% of 80% are not cured. That is why there is a feeling that cancer is not curable. But I always say cancer is the best disease. It's a fantastic disease, whether to treat or to have ourselves. Because all other diseases right now, whether it is diabetes, BP, thyroid, all the diseases what we have, they are neither curable nor preventable. I mean, they are a pain in the neck for you. Anywhere you go, you have a diabetes, you will ask the host, when are you going to give me food, because I have to take the injection. So everybody is in problem. But cancer is like a one-day cricket match. Where you kill the cancer, cancer kills you. It's a very good death. Very good disease also, because the result is decided very soon. But diabetes, you have the whole life. BP, you have the whole life. But why we are all joining here today, what we should do in these meetings, what should be, I always feel that in our country, out of 15 lakh new cancer cases, we have facilities only for 5 lakhs. Whether it's for, any treatment you take, or all the 3 treatments, the facility is there only for 5 lakhs. So, this is a good and bad news also. Good news is that for our students, for the people working in this area, there is a job for 50 more years. Like a doctor wants to choose a subject for his postgraduate, his or her postgraduate degree, cardiology, you throw a stone, falls on a cardiologist. If you go to general surgeon or general physician, I mean, they are in thousands or lakhs, in this country. But if you see the cancer, very few physicians. There is a lot to be done in cancer because 50% of cancers are preventable. हमारे कंट्री में, पंजाब में सरदार जी को ओरल कैंसर नहीं होता. क्यों? सिगरेट नहीं पी सकते. क्यों नहीं पी सकते? बिकॉज मेरा मूंछ 5 मिलीमीटर है, उनका मूंछ जो है 10 सेंटीमीटर है, जल जाएगी. तो प्रूफ तो हमारा कंट्री में. व्हाट वी नीड इज दैट टबैको कॉजेस कैंसर. आप किसी को समझाएंगे, आप आधा घंटा लेक्चर देंगे, कहाँ समझने वाला है? आप अगर ये अपने एग्जाम्पल देंगे, सारे कॉज ऑफ कैंसर हिंदुस्तान में ही है. हिंदुस्तान के आपको बाहर जाने की जरूरत नहीं. वी हैव प्लेंटी ऑफ कॉजेस ऑफ कैंसर हियर. वी हैव प्लेंटी ऑफ ट्रीटमेंट ऑफ कैंसर, बट सम पीपल शुड डू इट. The second most common cause of cancer in this country is human papilloma virus, causing cervical cancer. If I talk to the girls sitting in this hall, I think 90% have not been vaccinated for whatever reason. I mean, I didn't know, nobody told me like that, So this is a preventable cause. 60% cancers are preventable. 60% are early diagnosable. 60% are curable. What a better disease you can have. But what we need is this prevention, not that we are not doing anything. All of us sitting here, we are not sitting quiet. We are all doing. With all our effort, I can tell you what has been done. And let me tell you, whatever figures I am giving, they are all, in the literature, and you can find it whether our own National Cancer Registry Program or literature. If you see the cervical cancer in 1973 was 55, incidence was 55 per 100,000. Today is 10 per 100,000 in this country. तो काम कर रहे हैं तभी तो हो रहा है. कौन काम कर रहा है? हम सब मिलके कर रहे हैं. इसको जीरो करना है. In Kerala, it is 7 per 100,000. New Zealand, Australia, it is 0.5 per 100,000. So why can't we reach there? Number one, tobacco-related cancers are coming down. Out of 17 tobacco-related cancers as defined by IAEA, 7 are coming down. We have already achieved the goal of WHO, which we are supposed to achieve by 2030 already. तो हम कर रहे हैं, but we need to do more. As I told you, still then, the facilities which we are, the cancer number is very high in this country. We are treating only 5, out of 15, only 5 lakhs. And prevention we are doing because our patients are being presenting in stage 3. In fact, I always say they are not stage 3, 4, they are stage 15 or 20. बिकॉज अंग्रेजों ने बनाया था स्टेजिंग, अगर वो इंडिया में बनाते तो स्टेज 15-16 तक जाता. उन्होंने कभी 20/20 से देखा ही नहीं, तो वो 4 से आगे बढ़े ही नहीं. तो कैसे ठीक करेगा उसको? ऊपर वाला भी ठीक नहीं कर सकता. तो उसको ठीक करना हमारा काम है. एंड वी नीड टू डू, एंड सेंटर्स, comprehensive cancer centers like this, which are teaching center, are only supposed to do it. I think time is less. Thank you very much for calling me here. Thank you.
Thank you so much, sir, for your motivation. Now I would request Dr. Satyam Khare, sir, Vice Principal, Subharti Medical College, and Dr. H.S. Minhas, sir, Senior Medical Superintendent, Subharti Hospital, to felicitate Dr. Rath, sir. Thank you so much, sir. Now I would like to take the privilege to introduce our next guest of honor, Dr. Chintamani, Head of Department Surgical Oncology of VMMC, Delhi. Sir is a governor and president of American College of Surgeons of Indian chapter and also a fellow of Royal Society of Medicine, UK. Along with this, sir has been president of various associations. He has published more than 100 publications in national and international journals, along with being author of 10 surgical books and various chapters. Now, I would request Dr. Anurag Srivastav, sir, to please felicitate Dr. Chintamani, sir. I would welcome now Dr. Sunil Kumar Saini, sir, our next guest of honor on this event. Dr. Saini is a pioneer of cancer surgery, serving currently as Professor and Head of Surgical Oncology at Himalayan Institute of Medical Sciences and is the Director of its Cancer Research Institute. He has vast experience of more than 30 years and treated over more than 1,000 of cancer patients by performing complex surgical procedures. His efforts has enhanced cancer awareness, tobacco control, early detection, tissue banking, and palliative care in that region. Dr. Saini has published over 100 articles and completed many research grants. He has also received many awards, including Uttarakhand Ratan and Pride of Uttarakhand. With this, I would like to request Dr. Kishore, sir, to please felicitate the sir. Dr. Sunil, sir.
We will now embark on a journey of reflection and projection as we hear from Dr. Anurag Srivastav, sir, Director of Subharti Cancer Institute, who will enlighten us on the achievements of our Cancer Institute and the road that lies ahead.
Jai Hind, Namaskar. My great teacher of teachers, Professor G.K. Rath sir, Professor Chintamani, Professor Saini, Professor Kishore Singh, Professor Minas, Professor Dinesh, and all the distinguished oncologists, sisters and brothers. It gives me great pleasure to honor all of you on the occasion of the second annual function of the Subharti Cancer Institute. And I would just tell you about some general ideas about how we are dealing with the problem called cancer. And then Dr. Arun Kumar Verma, who is the first oncologist to join this center, he will give you the details of the data. So next slide, please. So United Nations has set up 17 Sustainable Development Goals, or SDG as we call them. Next, please. And the goal 1, or SDG, is poverty eradication. Goal 2 is zero hunger, no one should be hungry. So hunger eradication. And goal 3 is about good health and well-being. And then there are 17 such goals to be achieved by all the member nations by year 2030. That's the goal we have been given the assignment. Next, please. Of these, the goal 3 is the one that we deal with in medicine, in healthcare, and which means ensuring healthy lives and promote well-being for all at all ages. And this includes the treatment and prevention of non-communicable diseases and lifestyle diseases like cancer also. Next, please. So, to go in detail in relation to the cancer, SDG 3.4. So, in each goal, SDG 3, they have subgroups. And 3.4 says that reduce at least 1/3 of the premature mortality caused by non-communicable diseases. And of these, the heart disease and death due to uncontrolled diabetes and that due to cancer is of paramount importance. 3.5 states about strengthening the prevention and treatment of substance abuse, including tobacco and alcohol abuse. And we know that number of cancers are caused both by tobacco and alcohol or when they are abused together. 3.9 SDG states reducing the death due to pollutants, and we know that many pollutants such as air pollution, water pollution, food pollution, they are considered carcinogens, and the city of Delhi has the maximum air pollution, and we know that lung cancer is very common. Similarly, some other cancers are related to pollution, and the theory behind is that the pollutants combine with our DNA and cause epigenetic phenomena. So even if you are not born with some cancer susceptibility gene, the pollutants present in the air, in the food, or working on the skin will damage your DNA and RNA and will cause epigenetic phenomena, and this is leading to number of cancers related to pollution. So again, SDG states that we have to control that in goal 3, number 9. Stage 3A is again very important goal, as Dr. Rath said, that about 40% of all cancers in India are related to tobacco, smoking or chewing. And 3A states is strengthening the WHO program, which is going on throughout the world on tobacco control. So with these goals, we will be able to control the menace called cancer. Next, please. A famous book written by a great author, an oncologist, Siddharth Mukherjee in America, The Emperor of All Maladies, a biography of cancer. In the preface, he wrote, in a sense, this is a military history, one in which the adversary is formless, timeless, and pervasive. Here too there are victories and losses, campaign upon campaigns, heroes and hubris, survival and resilience, and inevitably the wounded, the condemned, the forgotten, the dead. In the end, cancer truly emerges as a 19th century surgeon once wrote in a book frontispiece as Emperor of All Maladies. So here we are, sir, talking about the Emperor of All Maladies, the cancer, And as Dr. G.K. Rath sir has assured us that one day we will conquer even the emperor of maladies called cancer. So with these, I welcome all the dignitaries and delegates for this occasion of the Subharti Cancer Update year 2024, and request Dr. Arun Verma to give you the details of our performance in the last 2 years, ever since the inception of Subharti Institute of Cancer Management and Research. Dr. Arun Verma, he is the first oncologist to join this institute, and I am proud to say that he has been trained by the world-renowned oncologist Professor G.K. Rath sir in IRCH AIMS. Dr. Verma sir.
Thank you, sir. Good afternoon, everyone. My name is Dr. Arun, and as sir told, I was the first oncologist who started oncology program in this center. Before that, before introducing about SIGMAR, I will go little about hospital. The Chhatrapati Shivaji Subharti Hospital. Here, every building is named in name of freedom fighter or our ancestor. The hospital is established in 2000 and it having more than 1,000 bed and 12 major OTs running daily with 24 into 7 hour emergency services, blood bank, and it is the main hospital of Meerut, which is covering this area. And if we see the scope of services which are provided by Subharti Hospital, it provided all type of medical services and running the PG program almost in every super specialty. And soon we start PG program in radiation oncology also. With this, in 2000, about 10 years ago, the founder of Subharti came with the idea to develop a comprehensive center which are not comprehensive cancer, which are not only dealing about the treatment, but much beyond that. It deals from the prevention, screening, and even after treatment for the survivors and palliative care. And with this thought, the Subharti Institute of Cancer Management and Research were started. And this was dedicated to the Dr. V.B. Bhatnagar, who passed last year. He was the first surgeon of Meerut, retired from LLRM and established the surgery department, and who started oncosurgery, chemotherapy in this zone when no one is practicing oncology in that time. So that's why it dedicated to sir. My presentation will run on the we have now on the about something about SIGMAR, and then the patient profile and what are the challenges we faced and what are the progress we achieved and what are the future vision. If we want to run a successful oncology program, then what we require an experienced team of surgical oncologists, radiation and medical oncologists, and that health care professionals should be empowered enough by available cutting-edge technology in the field of pathology, radiology and treatment, and they should be supported by the physiotherapy, rehabilitation, yoga, naturopathy, palliative. Here the naturopathy department department is doing very well for the patient support. Even they helping in the reducing the stress level and nutrition. They helping them cancer patient for the improving in nutrition. And as we are, I am radiation oncologist. As एक रेडिएशन oncologist क्या चाहता है आज की डेट में? उसका दिल यही चाहता है कि एक हाई एनर्जी लीनियर एक्सीलेटर हो डिपार्टमेंट में और ब्रैकीथेरेपी यूनिट हो. तो वी हैव दैट. We are fortunate, we have all, whatsoever I am thinking before joining for Subharti or any center, we have all, almost everything in this setup. We have a team of experienced stalwarts like Professor Anurag Srivastava and Professor Kishore Singh, and our very supportive fellow like Dr. Asiya Hilal, Dr. Anil, Dr. Badar, and our medical oncologist who is not available because he is going to marry in this week, and that's why not, and Dr. Umang Mittal, who is the leading oncosurgeon of Meerut, and Dr. Ritik Bansal present here. He is the MCS surgical oncologist. He will meet you in next presentation. And if we see for the cancer treatment, the first thing is a very good pathology department who are doing not only pathology reporting, they should also do the immunohistochemistry, PCR, if possible, NGS nowadays, and we having that. The NGS facility, presently we are limiting for the infection bacteriology only. We are trying to get NGS for molecular lab also for the cancer patients also. And among the radiology, it is totally revamped in last 1 year. It with newer machines like high resolution ultrasound, high speed CT scan, and digital mammography, MR mammography, 3 Tesla MRI, and all these are brought to the hospital in 1 year. And one of the USP of our radiology department is they are doing whole body diffusion MRI at a cost of 5,000, and that will look like PET CT. It giving information like PET CT. If patient is poor, then we will ask for the whole body diffusion MRI, and it is much cheaper than the whole body PET CT. But yes, we know the PET CT is one of the vital part, and that's why we also brought the PET CT, and it is not analog, it is the digital PET CT, which is the first in the UP, and it is also supported by gamma camera. Why we bought the digital PET CT? Because it is faster, it require lesser radioactivity, and it able to detect even a smaller lesion which are usually missed in the analog PET CT. For our department, it is complete setup. I can say proudly it is a complete setup because it having high energy linear accelerator with 6D couch, with radiosurgery that can perform radiosurgery, rapid arc 4D with RPM, and multi-channel high energy, high dose SDR brachytherapy with wide bore CT simulator dedicated to radiation oncology oncology department, which is available only in 30% of radiation therapy department only, maybe lesser. Mostly they are shared by the diagnostic city. But we are fortunate we having dedicated wide board CT simulator. Why we bought that? Because in radiotherapy we need a lot of accessories for patient positioning so that patient comfortably able to lay down for 15 to 20 minutes or even 1 hour in some cases, and that because of too much accessories, patient overall accessories and patient thickness diameter become too high, and sometime patient will not able to enter in the bore of the CT. So that become a limiting factor in some department if we share the diagnostic CT for the radiotherapy planning. So, but we are fortunate we not having such limitation. If the radiation oncologist knowing everything about the true beam, but no, for our other colleague, his major head is the linear accelerator, and side by the side two robotic arms are the they are the verification CT scan that can take fluoro, that can take X-ray, and it is the 6D couch which can move 360 degree, and it can flex in 6 directional. And because of that, this 6 degree freedom, we able to maintain sub-millimeter accuracy, and we able to treat even sub-millimeter, we able to treat sub-centimeter lesion of 3 mm, 2 mm, especially in brain. This is the real-time position management system, or we can call it a respiratory system, where one screen is hanged in front of patient eye, and a sensor is kept on the abdomen of patient, and that sensor is synchronized with the linear accelerator machine, and as the patient breathes, the machine senses the respiratory pattern, and as per radiation oncologist requirement, the radiation beam is fired either when the patient hold radiation or it completely follow the respiratory pattern. Based on that tracking, if it is completely follow the respiratory pattern, then it is called tracking system. If it is radiation delivered during the whole time, then it is called deep inspiratory breathe hold technique. But in general, they are respiratory pattern based radiation therapy or 4D radiation therapy. So because of these facilities available in TrueBeam, we can call TrueBeam if having these facilities like the Arjuna of radiotherapy machines, because it able to precisely treat even the moving tumor. It can treat the simple tumor, it can treat complex anatomy, it can treat whole body, it can treat any sort of complex radiation therapy, IMRT, IGRT, SBRT, SRS. The advantage of this high energy modern radiotherapy technique is that we able to precisely deliver radiation therapy where we want, and whatsoever we want to spare, we can precisely spare that. We can deliver high dose to tumor and lesser dose to surrounding prophylactic area. We can spare the normal tissue. We can, if sometime the tumor is very responsive to the radiotherapy treatment and it shrink in every 7 to 10 sessions of radiation therapy, in that case we need to plan for because the anatomy have changed, and with this we able to adopt the new anatomy. We can retreat, or even we can treat third time we treat if patient is treated earlier with the IMRT or IGRT things, and if previously the soft tissue spinal cord is spared from the previous treatment, then we can retreat. It can treat single lesion, it can treat double lesion, it can treat multiple lesion, and this type of stereotactic treatment, when it is done by the true beam machine, then it is called Yak's knife treatment. This is the total. It can do the, since we not started leukemia program and bone marrow transplant, we are on planning that. That's why we still not doing the total body radiation or total marrow radiation here. And total skin electron therapy, this is done at the previous center, where in true beam machine there is two type of energy. One is the photons or X-rays, and another is the electron. What is the feature of electron? It having a penetration of few millimeters or centimeter. In that the whole radiation get deposited, and beyond that the tissue get spared, and that's why it is used for the treatment of skin cancer, or the cancer those are developing in the skin, like lymphoma of the skin. In that case we require to treat whole of skin, and in this type of treatment is called total skin electron radiotherapy, where the deeper tissue get spared, only the skin get treated by the electron. Sometime we have done also the this ECRT, where the surgeon remove the diseased portion of bone, and then we treat that bone on the, we bring that bone from the OT in sterilized setup, and then treat with the very high dose, so that whole tumor get killed in a single session of about 50 gray. And then this sterilized bone is can be used as a biological processes, or sometimes we call a poor man processes, where the patient can't afford the fancy processes and costly processes, then the surgeon may use these things. We also have the brachytherapy, with all type of applicator. We can do surface, we can do the intraluminal, we can do interstitial, intracavitary, or interstitial brachytherapy. Recently, Professor Anurag sir have excised a early breast lesion of 3 centimeter, node negative, ER/PR positive patient of 75-year lady, and then we put these flexible catheter in the lumpectomy cavity, and then with the help of these catheter we did the brachytherapy to sterilize the lumpectomy cavity. The beauty of this treatment is whole surgery radiation therapy, which require a treatment of around 2 months, it get completed in 1 week. And since it is a ER/PR positive patient, and it also not required chemotherapy, and after surgery and radiation therapy, within 1 week, patient kept on the hormonal treatment and sent home and called 3 monthly. So that is the advantage of the interstitial brachytherapy facility if center is having. This process can also be done, we are doing in the soft tissue sarcoma, where the surgeon removes tumor, and then we put catheter and then do the brachytherapy, and we try to avoid external radiation, so that patient can be switched early for the systemic treatment. Over a period of a year, all sort of simple, complex, advanced radiation therapy was performed, whether it is a 2D, IMRT, IGRT, rapid arc, electron, stereotactic, If we see the patient profile or patient data of last year, we have registered about 1,963 patients and total OPD were around 6,000, out of which 800 plus were admissions and about 192 patients treated in the radiation therapy with 3,466 sessions over 1 year. And last year we have treated with 23 patients with the brachytherapy. Now in this session we have done around 37 brachytherapy in this quarter from January to March. So maybe previously we are unaware by the societies, and now the people are trusting us and knowing us. That's why whatsoever we treated in last 1 year, about 50% of we achieved in 1 quarter, in this quarter. If we see the patient profile, the head and majority of 50% patient were of head and neck cancer, and then followed by the breast, lung, and bone GI cancer. The cervix is little lesser. Maybe we are dealing with the very poor societies where because of financial reason or because of social taboo, the pupils are not bringing patient even for the treatment. They want to die because of social taboo, because of finances. We need a lot of counseling to these patients. If we see the territory, we getting patient from the Ghaziabad, Noida, Modi Nagar in this area, and then if we see going towards the Rishikesh, then from up to Rishikesh, most of patients from the Rishikesh and Dehradun are coming because of date issue in the AIIMS Rishikesh and Muzaffarnagar, and if Hastinapur, Bijnor. We also getting patient, maybe because of Ayushman, we also getting patient from Mathura, Prayagraj, Patna. So that may be because we having IMR full setup, brachytherapy and Ayushman facilities. They may be we are getting patient from these remote areas also, which are quite far. If we see the progress, we started we are regularly doing the multidisciplinary tumor board meeting and every alternate days, and we also doing discussing complex cases with the National Cancer Grid Virtual Tumor Board (VTB) as per their scheduled dates, and we trying to be patient centric. And if we show our department, it is totally paperless department. If patient is registered for radiation therapy, then whole of radiation therapy process is paperless. If from the registration, vital entry, patient prescription, patient analysis, and patient approval, everything and QA, everything is done through the care path, where if suppose I have completed contouring, then we have to enter in the Eclipse itself, okay, my contouring is completed. By doing that, and if I entered my password for completing contouring, then it automatically goes to next step, which is time bound. In that time that the physicist has to plan, doctor has to contour the case. If overshoot, then it get a red alert. And we also started the e-prescription system with the Adhere software. And recently, as with the effort of Professor Kishore sir, our hospital is approved for the hospital-based cancer registry, and in this month only, and we are starting that also. The challenges, I remember what we faced, mostly the aging population, we are getting aging population, family member are not motivated to take treatment or under alternative treatment till they develop advanced metastatic and incurable disease, as Professor Russell told. When they come to T10 stage, then they come to us. So, resource constraints. So we for last 1 year we are not having resident, and every we hats off to our faculty. They are doing each and every step whatsoever the resident are supposed to do. They are also doing that. The limited availability of trained and skilled staff who has experience in the cancer care in this area. The dedicated palliative care, we missing dedicated palliative care team and center, and soon we are discussing with Susma ma'am, maybe we starting the palliative program also. Limited funding, we did not have any NGO support. Sometime whatsoever the patient getting in under Ayushman, they get chemotherapy, radiation therapy, they get treatment. But if the patient require immunotherapy or higher molecules, then they are not covered in Ayushman, and they also not able to afford it or not going for that. So maybe if we getting some NGO support, then we can treat patient much better. Approximately 20% of patient and family are very poor and not able to afford repeated regular hospital visit, even that. So there is a gap between the health care and the society. The planning satellite, we recently the Lokpriya a center of Subharti with name of Lokpriya is set up in the rural area. That the planning rural center is started. So we planning for the more rural setup also, so that gap can be filled. We started virtual and video follow-up also. The future vision is to ensure that all patients receive equitable care regardless of their financial background. We are trying to collaborate with the local administration, pradhans, local NGOs to fill the gap between the patient and healthcare. Invite national and international NGOs, get research grant and develop Western UP data or research. Residency program in the radiation oncology to be started soon, maybe this year. Start medical oncology department when DM program, these are the future program, and start automatic ISC analyzer. Mostly ISC takes 4 to 5 days or even more. We are starting automatic ISC analyzing unit for the quick ISC reporting, and explore AI genomics to start molecular genetic lab for the better diagnosis and treatment. Start cost-effective bone marrow transplant units. Collaborate globally, partner with the other centers, share knowledge, accelerate progress. The focus on the prevention, not only on treatment. Get research grant to invest early detection, lifestyle intervention, cancer education and research. With this, I want to conclude. Subharti Cancer Institute remain dedicated to advancing cancer care with a steadfast commitment to innovation, compensation and excellence. Thank you. We started with a small team, and team is growing. This is the last year photo, and many members, professors, Kishore sir added. We missed. We need to take new photos. Thank you.
Thank you so much, sir. Now I would like to request Dr. Arun Kumar Verma, sir, to please felicitate Dr. Anurag Srivastav, sir. I would request Dr. Saloni Mehta, consultant nuclear medicine, to please felicitate Dr. Kishore sir. Now I would request Dr. M.K. Mittal sir, HOD Radiology, to please felicitate Dr. Arun Kumar Verma sir. To our keynote address, I would like to welcome chairpersons for the keynote address, Dr. G.K. Rath sir, Dr. Anurag Srivastav sir, Dr. Dinesh Pandekar sir, and Dr. Chintamani sir on the stage. I would request Dr. Sunil Kumar Saini sir to please start with keynote address on the topic comprehensive cancer care.
Luminaries on the dais, all of them in fact are my teachers, mentors, and those who inspired me over the years, and dear friends and colleagues in this audience. I really feel humbled with this invitation. Before I proceed further, I would like to share the secret behind it. Professor Anurag, he is my teacher for last 38 years when I was a resident. And over these years, I received his love and affection and guidance and mentorship. Whatever I could do through this life, I can attribute to him to a great extent, getting inspired by him. When he called me, I declined it, later on hesitantly accepted it, thinking this is the way my mentor is trying to bless me. So I bow down to you, sir, and I accept it with all humility, your invitation to share my experience and certainly my ignorance as well. Well, A bit about this institution and my institution. I can see a lot of young people over here. I come from Himalayan Institute of Medical Sciences, and here at Subharti Medical College and the Subharti University, known as Swami Vivekananda University. Mine is Swami Rama University. They started in 90s, and they grew parallelly with each other, taking lead in some or other areas, both of them. I couldn't have enough opportunity to come over here. This is the third time I'm coming. I came 20 years back for a lecture. Thereafter, I came last year in a workshop. And that is the time I got to know more about this place. Dr. Krishna, he took us for a round of a campus tour. And I could sense that there is so much of good thought, or the good deeds and good thoughts which are driving this organization. I could sense the nationalist feeling. I could sense the acknowledgement and contribution of many of the national figures. So I was sensing, well, every organization has something or other. It doesn't come up just like that. So that means something is driving them. So I left this place with a lot of warmth and a lot of respect for this institution and for the people over here, those who contributed to bring up to this stage. On the other hand, you can see the picture of my campus. In 1992, I had the opportunity to start a small tin shed clinic over here. There was nothing in this. It's in the foothills of Himalayas. And it was just a forest. So I got an opportunity. I was blessed by a saint to work with him. So that's how I started my journey. And the very first commitment in 1992 was he assigned me to build a cancer institute. Friends, let me share with you, it was a profound experience meeting him. Because that changed my perspective. That changed the formal education which I received in Banaras Hindu University and thereafter in cancer institutions. He enabled me to see life in a larger canvas, not just as a physical being. So possibly that shaped my thinking process while developing a cancer institute in my area. Before I proceed further, I would like to share something so that you do not mistake me or misunderstand me. I remain busy 3 days a week in operation theater and rest 3 days in my clinic until late in the evening. The cancer institution which we have is a 260-bedded cancer institution, and we have everything you count, which is required in a cancer institution in a modern time. We see close to 75,000 patients, old and new, every year. We treat 120, 130 patients on radiation every day. In my own career, I have treated personally in my clinic more than 40,000 cancer patients. And I might have operated major and extra major surgery close to 15,000 and plus minor and everything close to 25,000 of patients during my career of last 30 years. But I remained secluded in a small state because my busyness did not allow me to venture out, go to Delhi, interact. Professor Chintamani is my friend for last 20 years. He's been calling me time and again, but my time doesn't permit to interact more with them because my obsession was with common man, so that keeps me there. I don't move out. But let me share with you the story of building a cancer institute and how my thought process, which was shaped by a saint to begin with. Well, here is a slide, understanding about cancer. all of us see cancer from a different angle and different way. A biologist sees the cancer differently, an oncologist in a different manner, a surgeon a different manner, a social scientist maybe a different manner, and then someone who is planning for healthcare resources, he sees differently. Although we may keep counting numbers, I have quoted 2 reports. Well, they put up the figures, but within these figures we can find so much of diversity in the cancer as such, and the reason behind cancer, and the way we treat people, and the way they come out of their illness. Well, what I mean to say, that cancer is, we all know it's not one disease, and it is to be addressed at many different levels, different dimensions. We all know about these treatment modalities, very well outlined by Professor Anurag and team. I'm quite impressed the way they are thinking about it. That's the way forward. But here, my thinking, how it has been different from many others. Adopting these therapies, we have treated cancer just like we deal with terrorists. We have been chasing them wherever, like we tend to chase terrorists to knock them down with targeted therapies, targeted bullets. Same way we do that with our cancer patients. But we don't achieve anything without a cost. In this process, we cause so much of collateral damage. It is just like we are fighting a war within our body, giving these therapies. Well, these are essential. That's the only way. And we are modifying our ways to be more humble, gentle, with de-escalation, and with having more therapies which are less toxic. Yet, we remain quite violent in our ways of treating people. So in one way, we are driven with a killing instinct while we deal with cancer patients. I'm sharing this with young in this hall because it's important to see different dimensions and different perspectives, how we deal with illness. If we remain obsessed or remain too focused, we don't lead anywhere. So if we understand a larger context, perhaps we can make a meaningful impact on how we deal at a larger context, at a national or international level, and how we see the society in a larger ecosystem. So challenges in the current therapies have been a lot of side effects. It's not only physical side effects, lots of emotional and psychological impact. And no doubt we end up killing lots of people, not only the patient has toxicities, but many more people behind the scene, they die. Their career would die, their daily living would suffer. Many of the kids may remain uneducated because they exhausted all their resources while treating their patients or treating their loved ones. So we fail to see beyond our patients. So there is a need to see things in totality. So there is a need to organize things in a comprehensive manner. So while delivering these therapies, which seems to be so essential as of now, we have to take care of quality of life. Not only patient, but the family and the caregiver and everyone around. Well, I could see that the patient-centered care in the previous speaker also. Yes, that's the way forward, that we tailor treatment as per the individual needs and make a shared decision making. But these things are pretty much missing. Unless we learn to communicate with each other first, before we communicate with the patient, such thing won't come up. Such a disposition or such a prescription won't come up unless we learn to be friends with each other, unless we have enough of communication within the team. Well, as such a team, which is highly desirable, Let me share, at my institute, we registered more than 4,000 new cancer patients, and none of the patients would receive treatment without going through multiple people, either through a tumor board or through a clinical audit. Everybody get to know what someone has done. We would tell patients not to accept opinion or prescription for one single doctor. You have the right, we display in our hospital, you have the right to seek opinion from rest of the colleagues. And don't accept a treatment if a doctor says this is the only way you could be treated. Because there is always another way to deal with the problem. Well, other than oncologists, the point which I would like to make, other than oncologists, okay, someone is doing that, okay. So other than oncologists, well, there are more players. Another viewpoint, which I'm quite vocal with my local. Okay, I'll do that. Well, another viewpoint. Our healthcare system is too much doctor-centric. We are opening up lots of medical schools and we are churning out lots of doctors. I say we don't need that many doctors. Maybe for a while we might need, but we need far more nurses. We need far more allied healthcare workers. In a cancer institution, which is coming up here as well as at my place, we need 80% of the care is delivered by the nurses. If you need to orient anybody, if you need to educate anybody, it is the nurses, it is the allied healthcare workers, it is the receptionist, it's everyone around. A patient who has come to the hospital, he needs to go out with a good experience, where he feels respected, he feels dignified. How he benefits out of it? He benefits by maintaining his making right decision for himself, having faith in the doctor, feeling good about himself. If we simply fixing him just like a car, possibly we are not doing enough. Many of us may come up with an argument, well, our hospitals are crowded. Well, government is taking up, making efforts to undo that. Ayushman is one of the good schemes which is helping people, helping decongesting these institutions. Another aspect in this reference I would like to share, all these crowded hospitals, naturally they are driven by technology with little time for empathetic communication, empathetic care for the patients. But we need to bring that. So possibly our future time would see that. Well, it has been talked about supportive care services. So here I want to put my main emphasis, and I would like to share what we did about it. Although I'm a surgeon, I remain busy with surgery, but this is what I want everyone in my team. We have close to 400 people working in the Cancer Institute with us. And everyone who comes to us for a job or to work in cancer institution, we make them go through an orientation. First, they have to learn how to behave, how to talk to a cancer patient, how to communicate with the cancer patients. All our nurses, we have taken them through a palliative care course, which teaches them how to communicate. We don't allow them to rotate. We fight with the management, those who are looking into posting of the nurses, they don't rotate our nurses. They can't go to general ward and come next day to the oncology ward, because oncology care is so special and it is to be delivered through the nurses. I wish there were more nurses around here in this audience. Well, psychosocial support, as you all know, that's what something will bring down a moral of a patient which will keep haunting them. I would tell my resident, you have no business to prognosticate a patient yourself. A rotating resident from surgery, I said no. Only a senior consultant, a consultant can talk to a patient about the prognosis of the disease. Because breaking the bad news is something which requires a skill. That means we need to have enough time to communicate with patient. So this is what we do over there. The patient, every patient needs to have an informed consent. And when I say we do it, we're doing it, I mean it. Yes, we are doing it. Well, we've been trying to do things in a scientific manner, not just like that. Many of my colleagues, many of my students, I might have trained close to 40 postgraduates and those who wrote thesis with me, and then maybe close to some PhDs like that. And many of my colleagues, we did research projects together. So some of my colleagues, some of my team members, they studied about the psychological or distress and the depression amongst the patient. So we found in our own setup, close to 40%, 35 to 40% patients in our outpatient clinics are either depressed or in distress. 40% are at a given time, but when it comes to cancer, everyone during the lifetime, during the course of illness, every cancer patient goes through a distress or depression. But many of them, they recuperate, they come out, but many others may continue to remain depressed. So that means there is a need to address it, to enable them to cope up. If they don't cope up well, they don't follow your prescriptions. Whatever, you can get the best machine in the world. If he's unable to cope up, he's not able to continue your treatment, it's of no worth. Another thing we did with one of the, we've been working with Dr. Sushma Bhatnagar very closely. In addition to this, we worked with, I forgot to, okay, all right, I'm here, okay, sorry about it. Well, okay. Well, this is about a pain-free hospital initiative. We did it close to 6-7 years back, where the objective was that every patient who is admitted in our hospital, we must record his pain score, distress score. So we educated all the nurses, we educated all the doctors, and for last many years, we have every day a nurse would nurse would make him to see the chart and record the pain score and distress score. It's documented in the file, and doctor has an opportunity to go and see that. Sorry. Okay. Well, this is what we display in general ward, in all the wards. Okay. And how we take care of it? Thereafter, the nurses would go for a round, and we have separate palliative division, and where the nurses, we have full-time nurses, we have part-time nurses. Like how we have done it, that every nurse in charge, irrespective of what they are supposed to be part of the palliative and supportive care as a team leader. Then we have full-time nurses, and rest every nurses also need to have an orientation. So this way we record pain of every individual who comes to us and address it. Another thing, we've been taking care of the family and the caregiver. So we quite often ignore this aspect, that while taking the patients through a treatment, the caregiver would also suffer. So we do whatever we can do for them with better communication, facilitating, and creating an environment of conveniences. So one of the study which we did, one of my colleague over there at the Cancer Institute, they found at the end of the life, more than 50% 80% of the patient, they prefer to take their loved one home, to die at home, rather dying in the hospital. So these are the things, learning things, rather dumping everyone into an ICU. It's better to take them, allow them to take home. This is another about nutrition. This is one thing we identified through many of the studies done at my institute, that nutrition, while they go through the treatment, is very important. Otherwise, many of them, they drop out. They drop out of radiation, they drop out of the chemotherapy which is going on, or there are disruptions. So it's important to address it. One of my students who did PhD on oral care in reference to nutrition only, he identified 30 to 35% of patients, those who are undergoing some kind of treatment, they suffer from oral health related issues where they fail to maintain their nutrition. So he developed a protocol. He studied, did a randomized studies on how to improve the oral care, doing enhanced oral care protocol. So, and we have a very active dental clinic or dental service within our institute. So as I was telling you that we focused a lot on nursing professional. When I'm conceptualizing the Cancer Institute, I was very clear that I can hire one oncologist less. Rather, I would prefer to hire more nurses. Another thing which we try to do to elevate the self-esteem of the nurses, make them feel partner into care. Nurses at my institute, they would come and present in a medical doctor's audit about whatever they did. Every week they do it. So we have tried to bring them closer to us, to give a different feeling to our patients. And as I said, we don't allow them to be rotated outside the Cancer Institute. We resist that temptation by the management. Another thing is allied healthcare professionals. We all know that we are short of actual needs, but we need far more of them. And as of now, we have shifted some of the tasks which otherwise physiotherapists were supposed to do. We are asking our nurses to do it. Dietitians are less everywhere, so we have asked our nurses to take care of this part. So this is about physical therapies. We tend to forget during the treatment, after the treatment, even survivorship. These are very important issues. So we can't make cancer institutions just putting up equipments and machines. So we have to organize things in a comprehensive manner. Coming to something about integrative therapies, at the outset I would like to say I'm not promoting integrative therapies, or someone of you may think I'm representing any political party. I'm not. Okay, but I do see a merit in accepting or be receptive to the ideas of integration. One of my PhD scholars did study a randomized trial on using stress management through yoga therapies and found it did benefit, and we had multiple publications out of this. Patients who were receiving chemotherapy were given, you should have told me to, I remained focused, okay. I'm sorry, sir. Let me see here, I'm seeing there only. Okay, this is about the study, a randomized trial done by one of my PhD scholars who recruited more than 100 patients and did a randomized study on using yoga therapy on patients receiving chemotherapy. This is another of my colleague who used Yastimadu. Yastimadu is Mulati, where he used this in a randomized trial on 150 patients and found it's useful for reducing the toxicities of the radiation. This is almost 20 years back. One of my students did on quality of life. So the quality of life issues have been haunting us since very beginning, where she studied how in advanced cancer, quality of life is impacted. Then another student developed a prediction model for cervical cancer for quality of life related issues. Coming to spirituality in cancer trajectory, this is an article by a foreigner, not by any Indian Swami. Well, we may argue about it, but certainly we know someone who has peace within can make better decisions for themselves, for others. I would like to route the spirituality through a different way. And I would like to say, first, the caregiver, be it doctor or nurses, they need to learn to be at peace with themselves and with colleagues and everybody around to do good to their patients. So being peaceful within is so important. If it is important for you, it will be important for themselves. If they learn to, that enables them to cope up well. It enables the patient to cope up well. The diagnosis of cancer or the treatment of cancer, it enables the family to cope up well about if they miss out or if they lose a loved one. So it all depends on their beliefs and their faiths. If someone has it, we have no reason to deny to them. Well, one of my another colleague did a randomized trial on gentle therapies, and that is which are very less talked about metronomic chemotherapy. And our objective was we get lots of patients, those who come to us from Himalayas, travel 300, 400 kilometers to reach to us. It's difficult to deliver them injectable therapies or something which they cannot buy from any here and there. So he experimented with, again, the same which is common, metronomic chemo with methotrexate and celecoxib. And certainly we found that in head and neck cancer, it overscored over the capecitabine and those who were not given at all. So this is another randomized trial which we did. Another thing which, I saw last time the facilities in this institution which were quite fascinating, the building, the place of radiation oncology, but I would like to say, yes, it has to go beyond that, including the wards, including the corridors, including the outpatient clinics, everywhere. Building and spaces, the corridors where we move, also gives us a sense of well-being. And it makes us, whether we feel threatened going inside a building or we feel good about it. And eventually it impacts how we feel visiting a doctor or visiting a hospital. So it doesn't mean that it has to be very fancy. It could be simplistic and minimalistic. So we can make things in a very elegant manner. So overall, the goal is to improve the patient experience as they visit us. Well, those who are from crowded hospital, they may find all these things little obnoxious, but I'm telling you, the world is changing, our country is changing. Modi is looking towards making it the developed nation. We can't become a developed nation if we remain so crowded. Or so, I mean to say, we have to improve upon. It's not only that how the buildings or the corridors or the spatial structures within the building are fashioned, that impacts how we feel inside a building. Well, we're feeling good inside this auditorium. So same has to happen in every clinic, every place. So these things, this technology, these thoughts have to come. We have tried to integrate that in our place. Well, this is one more aspect, that is addressing financial toxicity. Well, possibly many of them, they get killed without really, okay, I got it, I'm just finishing it. Okay, so other is financial toxicity. I would say at my place, Ayushman has really helped us. And 80% of patients we treat through Ayushman. Well, technology we do use, it's hopefully coming up. Cancer survivorship is another thing which is coming up, and the need was always there. It's only lately we are waking up with these realities and designing our clinics. Okay, I'll just skip it. Research and innovation. Well, I would like to say our host has showed some slides about research and their motivation to go forward. Well, at my place, we have recruited lots of scientists. We have created 2 endowment chairs, one after a Nobel laureate who is the chair of one of the, who is with us as a faculty, another a senior scientist from America. Both of them are with us, chairing the endowment chair created in their name. And we have some scientists totally recruited in our cancer institution whom we want to work closely. Well, maybe I would like to skip advocacy and policy. We being close to Dehradun town. Dehradun is a capital, so we had plenty of opportunity to influence the way government is thinking, and we have been able to help them to shape some of their policies. Well, those who are in Delhi at a national level, they have a larger opportunity to influence the globe. In conclusion, something I would like to share. Well, our country needs more than 1,000 cancer institutions. Every 1 million of the population needs to have a cancer institution. Every district needs to have a cancer institution. And where they need to be placed? They need to be placed the place like Subharti Medical College, because a medical college provides a unique opportunity of delivery of multidisciplinary care, where everything is available and things which are available are cost effective. And it's not only clinical care, it's education, it's research. So the medical schools must become the hub of cancer institutions. So let us hope by 1947 we have 1,000 of cancer institutions like this. Those who are into private practice, I recommend they must be in a group practice with a seamless sharing of information with each other. So with these thoughts, I stop here and welcome any question or any comments from all of you. Thank you so much. Okay, thank you, sir.
Yeah, thank you very much. I think
In closing, let us unite in our commitment to advancing cancer research, treatment, and patient care as we strive towards a future free from the burden of this devastating disease. Thank you, and let the second annual Foundation Day of Subharti Cancer Updates 2024 commence.
At RGCI Delhi for kickstarting our event with a discourse on artificial intelligence in oncology. The session will be chaired by Dr. M.K. Mittal, Dr. Surbhi Gupta, Dr. Mohammad Shadab, and Dr. Poonam Goswami, along with Dr. Anuj Kumar Tyagi.
So very good afternoon.
It's my pleasure to invite our next speaker, Dr. Kundan Singh Chopal. He's a senior consultant and chief of thoracic breast and sarcoma radiation oncology service at RGCI Delhi. He has a very vast experience of 22 years and teaching experience. He has more than 100 publication, out of which most are international publication. And I'm sure that he is having a very high natural intelligence quotient to talk on the artificial intelligence in oncology. Now it is over to you.
Thank you, Dr. Surbi. By the way, Dr. Surbi is my senior from SNMC Medical College, so 1 year senior. So it's just a senior batch. So you must be knowing that how close a junior and senior batch is. With that, I would like to thank Kishore Singh sir for inviting me for this wonderful scientific meeting. So what I am today going to talk about is slightly different from what we have been listening till now, just to change the mood. So nowadays there's no meeting where you don't have any talk on artificial intelligence. So whether you like it or don't like it, this is going to come. So I would be very briefly, because it's a very broad topic, so I will be very briefly focusing on the very higher level view of what artificial intelligence is and how is it making inroads and how we have utilized these modern things into our practice. I think I'm not able to. Yeah, this is fine. So this was way back in 2018 when we met Dr. Miller in one of the meetings. He's from Australia, radiation oncologist from Australia. And what we realized was when I was discussing, so he talked about something called a radiomics. Then we looked back into these things, what exactly the radiomics is. And what we found was it is quite a innovative kind of a thing, where what you are doing is basically you are just analyzing the images, and from those images you're just taking out some specific characteristics from those images, because these medical images are nothing, they are just numbers, 0 and 1, 0 and 1. So you're just taking out the pattern from these numbers within the region of interest and trying to find out whether there is something which is informative about that particular region of interest which you are studying. And there were a lot of hiccups. I think there are some issues with the slide. So yeah, so there was a lot of hiccups in our journey. We tried to collaborate with IT people, we tried to collaborate with so many people, but again the issue was a domain knowledge gap. So there was a big gap between the IT people, what they knew, we didn't know, and what we knew, they were not able to comprehend what we want from any those sort of these products. So thanks to COVID, for 2 years we did many courses, and probably we ourselves, some of our team members actually, they tried learning coding and everything, and probably we developed some of the algorithms for studying these AI or deep learning models. Next. So just to give you a glimpse, this is for since 2018 we have been doing many research and publications, but if you look at the 40% of these research since 2018, once we embarked on this journey, are related to artificial intelligence. So be it cancer esophagus, be it a cancer lung, this is basically our unit which we are dealing with, so most of our work is on those parts. Next slide. So with that, if I give you a very brief introduction of what artificial intelligence is, go back, please. Yeah. What artificial intelligence is, there's a very broad field of data science, and within this ambit of data science, you have artificial intelligence, and within this artificial intelligence, there's a machine learning, and if you go dig deeper, then it is a deep learning. So as you go deeper, then the complexities and the kind of things, the algorithm which we are using, they become more and more complex and more difficult to do it in a normal routine work. Next, please. So with that, who is a data scientist? And I would very confidently can say that we clinicians are definitely a data scientist. Next slide. Click. Because we are expert in recognizing the medical data. Go back, please. Go back, please. So because we are expert in, we know what our problem is. Actually, we can see what exactly the issue is with the data and what are our questions. So what we need to find out. So this is the domain gap. Actually, we know what our problems is and how to deal with that problem and how to apply those modalities which are available in the form of artificial intelligence. How to utilize that. Next. Next slide, yeah. So this is a very simple thing. We do routinely, like breast radiation in all our patients. We just looked into the question like if we are doing some kind of a contouring. I'll not go into detail. There are two different ways of contouring breast cancer patients. So whether that is having any difference with our planning part and whether we are achieving something same or not. So these are the questions which a data scientist, a routine data scientist or a coder cannot generate. This has to come from within us, and that's why I say that we are first the data scientist. It's not important that you should know the coding part, but you should know how to perceive the things, how to perceive your problems, and how to put it forward to any of the IT people that this is what I want from whatever you are doing. Next, please. So a lot of black screens, so. So this is a part of artificial intelligence, the failing artificial intelligence. Can you switch to that other presentation? Yeah. Till the time they are putting up the slide, what artificial intelligence, exactly how it works, is a very basic principle actually. So there are some mathematical formulations and equations. So what you do is you give a lot of data to these algorithms, and you also give them the outcome of that particular data. For example, just take an example of CA esophagus, and how is this works? Yeah. So this is what I have already dealt with. So there are two main applications of artificial intelligence. One is how to make the processes better, and the other is outcome. So I will primarily be focusing on the outcome part of it, which is basically the predictions, outcome predictions. The concept here is, as I was telling you, this is the basic concept of any artificial intelligence algorithm, where you have an input, and with that input you also provide the answer to that algorithm. What is the output? It tries to extract some features or knowledge from this input and try to predict the outcome. And if that doesn't matches it, then it goes back to the input part, and again this whole process is to and fro process. It goes on doing that part, and once it achieves a particular kind of an accuracy, then there you stop. So in machine learning and deep learning, the basic difference is in machine learning, this extraction of features is manually done, which we have to do by using some other algorithms. In deep learning, this is a very straightforward process. You input the image or whatever thing you have, and you directly get the output. So in between, what is happening is we don't know. And that is also some of the critics say about that this is a black box effect. Because as a a clinician, if we don't understand what is a rationale and a logic behind why it is interpreting something as good or a bad, then usually it is very difficult to accept these things. But with time, this is also getting better. And this is what I was talking about. This is the deep learning algorithm, and this is what exactly we are also doing. So you can see that there's a CT scan image, and there is a lung cancer. We mark out this area, and this image is directly transferred to these convolutional. These are algorithms. They are nothing. They are just mathematical equations. And this image passes through each of these layers, and it extracts the information from this image and try to find out some particular pattern which is there in this image. On the basis of that, it tries to interpret whether this will be a good outcome or a bad outcome. And if it predicts wrong, then everything goes back. Everything propagates back, and whatever it has learned, it tries to twist it and try to increase or decrease the weights of these particular layers, and it again proceed further. And once it achieves a particular kind of an accuracy, then you froze this model and you provide with the new data where you don't know the outcome, and then it tries to predict what will be the outcome. And this is what is happening. These are all numbers, and this is going through each of these are the convolution algorithms which are going through these numbers and generating some pattern out of it. And once you get these patterns, then you try to get further deep down into these patterns and try the maximum values from each of these images, and finally you get something which is like a very subsample of that particular population, but still preserving the geographic location of each and every entities. And then you flatten this like a normal CSV data, and then this goes into this algorithm, and then finally you predict the outcome. So this is what the summary is. And if we look at the processes, so this is something which is like a data set which has been found. This is quite widely quoted study where there was a study among the radiologists and between the human readers versus using AI, how it was impacting, and they could reduce the workload by 86% by using AI algorithms. So this is not something which is going to replace the doctors. This is kind of a decision support system where you provide and triage the high risk cases, and which directly goes to the doctors, and rest come through the normal routine workflow. Same way, this is basically in radiation oncology, the segmentations. We all know now it is on many of our workflow where we have auto contouring, auto segmentations, though it is not something which is AI based. Most of them are heuristic based, but still this is also coming in a big way. The same way, this was AI based treatment planning, but the interesting part is AI based treatment planning was very good. So this was, when it was assessed, it was very good, but when it came to deployment, there was the confidence of deploying those plans to actual delivering the patient was quite less among the clinicians. So you are using AI, you are generating good plans, but still you are not confident to use them in the routine clinical practice. So this is a big hurdle because lack of faith, which I was talking about. So why it is making a good plan, we don't know. The logic and rationale behind it, we don't know. And this may be the reason of less confidence. And this is what we are doing in our setup here. Like Dr. Arun was talking about deep inspiration breath hold. This is a technique which requires a lot of resources. For 3 days, patient has to come to your department for assessment, and then finally you decide on the 3rd day whether patient will go for DIBH or not. We just try to find out on the basis of routine X-ray, which every breast cancer patient do. You put this algorithm to this, put that X-ray to this algorithm and try to find out whether this patient is eligible for DIBH or not. This was our recent study, which actually had a very good accuracy, 93%, and validation accuracy of 80%. And when we back propagated the weights of these algorithms into the image, so we wanted to reduce the black box effect. So we wanted to see why this algorithm is predicting that this patient will go for DIBH or not. So actually it was focusing this colored area, which you can see, the dotted bright fluorescent area. This is the areas where it was focusing to decide why this patient will go for DIBH or not. So if we look at the overall aspect of how artificial intelligence is making inroad, so whether it's being screening, classification, treatment, response assessment, prognosis, follow-up, in each and every aspect of cancer continuum, we have application of artificial intelligence. And if we look at our journey, so I think I've already gone through this in the previous slide. So this is what we did is, again, this was another case where we, in a specific cases of CA esophagus who are undergoing a new neoadjuvant chemoradiation, the cross protocol, followed by surgery, and majority of patients, almost 40% of these patients, they do have a complete pathological response. So we tried to predict on the basis of initial CT scan images whether this patient will have a clinical complete pathological complete response or not. And this again, we utilized this cropped images where the esophagus was there. We inputted these images into these algorithm, and we tried to find out whether these patients will have. And this also we published. So this had an accuracy of 75%. Now the future plan is we are now inputting both the images, the pre-neoadjuvant chemoradiotherapy images as well as just prior to surgery, the image which has been taken, and try to predict along with the clinical data into these algorithms. So better the information, probably more the information, probably we can increase the accuracy. This is our hypothesis, but it's still this is work in progress. So finally, can brain be replaced? So I asked this question to ChatGPT, and what it replied is, which we all expect, no, radiation oncologist or brain cannot be replaced. So we have to realize that we don't have to get afraid with these AI technologies. Probably we have to embrace these technologies, and this will become your part and parcel. So probably our roles will slightly change in future, but still the supervision will definitely be required, and they will definitely become a decision support system for you. What we did along with Dr. Munish and many of us, actually we form a foundation where we are trying to reduce this whole data collection and this whole machine learning algorithm or AI pipeline to smoothen it actually. If you look at a traditional workflow, so if you have a clinical data, you collect clinical relevant images, it actually takes almost a year. And then once you have to do a pre-processing of these images, which is a very difficult part, the medical images to transform into those entities which can be understood by those AI algorithm. And then you do a model building and these all stuff. So this, again, everything takes approximately 12 to 18 months. So this whole process is approximately 2 to 3 years. We came up with an Oncflow Care Plan, which is a foundation which is basically right now we are using in our department also. This is basically a radiation oncology workflow primarily focused on, and once you open it, you will have, depending on what kind of patient you have, like we have a breast unit, so majority of PubMed articles will be breast. Accordingly, you have everything on the right side, you have all your team members, and then on the left
AI can't work for a single center, definitely, exactly you are saying. We have to go for the multi-centric study, then only we can justify the results of the any AI model, either it is the machine learning or the deep learning. But there is some checking to be done, that within this limit we will accept, suppose the contouring AUC curve you have shown the 75% is the accuracy over there. Then if one of the center is doing within 70 to 80%, then it will be accepted. If it is going beyond 80%, plus minus 5% accuracy to the average accuracy, then that data to be rejected. Otherwise, the data, our AI model will always get confused. If we have 100 centers and 20 centers are not contouring properly, like our brain, the model, deep learning model is doing, there also the neuron, and it will always get confused. What you are saying, the multicentric study will definitely help in your model, but if we don't exclude the bad data, we can say the black data, then accuracy will not improve, I think.
So that's what I told you, garbage in, garbage out. The data has to be validated properly, so it will only learn from the data. I think we have a buzzer on.
As per your experience as an oncologist, as you know, there are various steps in the management of a cancer. So right from the diagnosis and pre-planning and the various steps of planning, where have you till now, whatever the data has been available to you, where have you find this AI as the most beneficial in which step? One thing, and the second thing is, in nutshell, what do you say AI is competitor or complementary or supplementary to us?
So, if we look at the practical application, it is mainly in radiation oncology and radiology. As said, it has been used. So, diagnostic thing, and in radiation, mainly in the contouring part, so which is being used. But in terms of clinical outcome, I don't think there is any clinically validated model which is being used as such in the clinics. So because again, the issue is the kind of heterogeneity and the generalizability of any model is not there. So it will take some time. I think first of all, there should be an acceptability, whether we accept it or not. And then probably if we all agree and collaborate, then only we can have some robust model which can be used in a generalizable form. So that's what I was telling you. Federated learning is something which will actually probably will solve this problem. Thank you, ma'am. Thank you.
Grateful for your contribution to today's discussion. Now, ladies and gentlemen, I would like to invite Dr. Mohammad Shadab from JNMC Aligarh to come forward and present a token of appreciation to our esteemed speaker, Dr. Kundan Chufal. So, please. Now I would like to request Dr. Jaya Shukla from PGIMER Chandigarh to enlighten us on the next topic of the day, which is Targeted Cancer Specific Detection and Therapy, Newer Vistas of Theranostics. This session will be chaired by Dr. Anurag Srivastav, Dr. Saloni Mehta, Dr. Sudhi Kamboj, and Dr. Anshul Vishnoi.
They will move the slides.
Is this your presentation?
Yes.
They will do.
They will do.
Yes, please, we can share this one now.
This is the one, no?
This
How
is,
to?
I'll just check.
First of all, I would like to thank Professor Anurag sir for the invitation and the entire organizing team. And sir is always the inspiring force for doing something new. He's always been there to help me and to encourage me to do new researches. So thank you, sir. So today I'm going to talk on targeted cancer specific detection and therapy, newer vistas of theranostics. Next, please. Okay. So nuclear medicine, I think now it is an integral part of the cancer care. So everybody is aware of nuclear medicine. So I just want to give you a brief introduction that some of our colleagues say that it lights the lamp. So it is lighting a lamp inside the body because we don't know what is inside. So we are dark about it. So different imaging modality like CT, X-ray, and MRI, this gives the internal anatomical details. But what nuclear medicine does, earlier it was known as a functional imaging. Now the time is changed, we are also giving some therapies, so it is now known as the personalized medicine or the precision medicine. So the light which is seen here is basically the isotope which is there, and the detectors in the form of gamma camera and the PET scanner, they can image they can detect that radiation which is coming inside the body. These are the penetration radiations captured by the gamma camera or the positron emission tomography scanners. So it is giving, but alone it is not giving anything else. It is just lighting the lamp inside. So see the collaboration or when it is collaborating with the anatomical part, that is anatomical imaging. So it is giving the coordinates where the light is coming from. So functional and anatomical imaging gives the holistic thing. It is done by gamma camera or the PET scanner. So this is our institute's PET center where we have a cyclotron which is producing different isotopes, and there is the next one is a generator, the right side one. Generator is basically the pregnant mother giving birth to the daughter. So this is generator where we store the mother, and it is giving daughter, and we are interested in daughter. So we preserve the mother, and we house the mother, and the daughters are coming. So we take it out the daughters and use it. And this is the synthesis module for PET scanner. And the lower one is automated one, and the second one is manual. So we now, as the nuclear medicine is functional imaging, though, so it is not the radionuclide which is giving the functionality. Functionality is given by the molecules which are of the biological importance. They are either the part of the metabolic process or the biochemical pathways. So first, the darling of nuclear medicine is FDGs, radio labeled F18 glucose. It is, I think everybody who are in this hall are aware of FDG. So this FDG is nothing but the glucose, radio labeled glucose. As we know, every cell needs glucose as a food. But where the cells are growing more, there are more demand, and even in tumor cells, it is a Warburg effect also. So the glucose is taken up by these cells. So FDG is used for the diagnosis, the initial diagnosis, or the response evaluation, and also for the restaging. So here the first one is for the initial diagnosis. The second two images are the pre and post therapy images. So you will appreciate that the patient is benefited from the medicine. It is responding to the therapy. It is also used for PET guided biopsies. Many a times there is a sampling error or the manual error. So we see the disease inside the PET scan or the gamma camera, and we precisely take tissue from the highlighted one, the hot area. Otherwise, in the tumor there is a necrotic area also sometimes, because wrong sample maybe. If we are not seeing the hot area, we can take the sample from the necrotic area or just adjacent to the tissue. So it is always better to get the sample which is actually required. So these two images are showing the guided biopsies. The second, another compound which is also very important, it is L-thymidine. It is a DNA precursor. So where the cells are growing, the DNA demand is also more. So the thymidine is taken up by the tissue passively, but it is accumulated due to the phosphorylation. But this F18 labeled thymidine is not taking part in DNA synthesis, so it gets accumulated in the cell, and we can image it with the PET scanner. So in the first, we can use it for the initial staging also, or in the responsible. In the first slide, you will see the favorable response, and second one, there is a disease progression. So we get to know whether the patient is responding to therapy or not. This is uniquely done. I think nobody is doing this. This is one of my BMT handling colleague. She asked that as it is a part of DNA, L-thymidine is a part of DNA. So she said that can we image transplanted patient, so it will reduce the number of biopsies, and which is very invasive, and it is very torturing also. So she is doing at day 30 and day 100. So there are some technicalities, technical issues, like it should be produced when the patient is there, and it is produced, F18 is produced in cyclotron, so it is a very costly process, and we cannot produce F18 for one patient because it is a very lengthy and costly process. So we try to take 2-3 patients also. If they are there, then we can do it. But it is not that, data is not that, it is not generated as we required. So I'm not thinking of making F18 gallium labeled, because gallium synthesis is very easy. We can prepare 2 to 3 times, and as the generator, with the help of generator which is on-site generator. So this is also very good for getting the information whether the bone marrow transplant is working fine or not. So next is choline. F18 choline is a cell membrane material. So cells are dividing, so it needs choline for membrane formation. So this is also used, mainly earlier it was used for prostate cancer imaging. And it is also used for parathyroid adenomas to see before surgery how many adenomas are there, what has to be removed or not. So then the surgeon has information about the adenomas. Then comes to the receptor based, the DOPA is as I mentioned, a multi-receptor targeting molecule. It is converted into dopamine inside the body by the amino acid decarboxylase, and it enters to chromaffin cells and deposit there. So it is also used for insulinomas, neuroendocrine tumors, neuroblastomas. And also it is a ligand for D2 receptors for neurological imaging. Sodium iodide, it is an ancient one, but it is still there. Nobody can replace this sodium iodide, iodine 131. It is taken up by the follicular cells where the sodium iodide importers, via the sodium iodide importers, at the thyroid hormones require more and more iodine. So there is always hunger for iodine. So even if we put iodine on the skin, it will go to thyroid. So this thyroid, as in India we are not having iodine 123 for imaging. So we are, because it is a theranostic isotope. Iodine 131 is emitting 365 keV gamma emissions, and also it is emitting the beta. So gamma part is used for the imaging, as you can see the images there, and these are the post-therapy imaging. And before therapy, we also do the diagnostic imaging to see how much iodine is taken up by the thyroid cancer. Now coming to the radiolabel biomarkers, these are the ligands for the receptors, and receptors are the biomolecules and the ligand are also biomolecules. So we don't want to disturb the integrity or the identity of that molecule. So what we do is we add one BFFCs, biofunctional chelator, that is actually chelate the metallic isotopes, so like gallium, lutetium. So we add this, we attach this bifunctional chelator so that radionuclide part is there, and we put a linker so that there is no steric hindrance, and the molecule is capable of binding to the receptor. So based on this, we are doing PSMA. Everybody, it is also a very wanted molecule. So the PSMA scan is PSMA and DOTA knock scans are very much needed. So it is also a transmembrane protein. This is basically an enzyme, and it is it gives very nice, as the PET imaging itself is a very good imaging. Image qualities are very good. So it is used for basically the prostate cancer, and nowadays it is also used for some other cancers also. So people are thinking of changing the name. That is, this is prostate specific membrane antigen. So it is now also used for the breast cancer imaging also, and we are also doing the prostate PET guided prostate biopsies. So we are also doing, as I said, that nuclear medicine is now providing the therapy also, and that is the targeted therapy. So first we see whether the diagnostic molecule is taken up by the cells or not, by the tumor. If it is taken, that you can see in the first image, and we have given the actinium-225 PSMA 617. So 617 is the name of the ligand. So after the second therapy, we did a scan, and you will appreciate that patient is responding to therapy. And in this, even after one therapy, the PSA level goes down. So as I told you that gallium PSMA is also used for breast cancer. So it is, we can give therapy to metastatic breast cancer also. Next, the important is the somatostatin receptors, which is widely expressed throughout the body but overexpressed in neuroendocrine tumors. So this is the image first one is, it is the gallium, the diagnostic, the PET radionuclide, and the next two images, the yellow one, are the post-therapy images of lutetium-177 dotatate. This is another molecule targeting the angiogenesis. As we know that integrin alpha 5 beta 3 is overexpressed in angiogenesis. So and there are motifs, repeated sequences in that receptor, for which we use a tripeptide, arginine, glycine and aspartic acid. This tripeptide, when labeled with gallium, gives the PET imaging, and when it is labeled with technetium-99m, it can be used for gamma camera. So it is giving nice images. We have also treated untreatable like tennis, the iodine refractory thyroid cancers. As iodine, they are not avid to iodine, so there has to be some other. So we tried that in the first image, we have scanned that this patient is taking the high uptake of gallium, RGD is there. So we have treated this patient with instead of iodine, because iodine was first image is iodine. There is no uptake of iodine, but there is high uptake of gallium RGD, gallium 68 RGD. So we have treated and patient was responded. So we have, this is just for the comparison that what is the difference between RGD and the gallium based and the glucose, the high demand of glucose in brain. So there is lot of uptake in brain. So it is difficult to see the brain metastasis or the bone skull metastasis. So you will appreciate that here in the first image there is a skull lesion which was not seen in FDG. So it is a good agent if you suspect that there might be some brain metastasis or the skull metastasis. We have another new molecule which is given by my collaborator in USA. They have synthesized this integrin antagonist carbamide. This is again targeting alpha 5 beta 3. And you can see it is taken by, it is showing the skull and the it is a highly metastatic disease and it is picking up all the lesions. And as it is labeled with gallium, we can treat this patient with lutetium-177 ISC. Then again, there is another compound that is the chemokine receptors. It is mainly, mostly in many cancer, we have seen expression of CXCR4, chemokine receptor 4, and mainly it is, we are treating the patients, imaging and treating the melanoma and the lymphoma patients with the lutetium CXCR4 antagonist. Now beyond the tumor cell, we are now targeting the tumor microenvironment or the stromal targeting. So in the stroma also there are a lot of many cells, but there are fibroblasts, which are normal fibroblasts, which are converted to cancer specific cancer associated fibroblast by the chemokine, which is secreted by the tumor, and we are now targeting these using fibroblast activation protein inhibitors. So there is a lot of role of inhibitors. We have several inhibitors in the market, but few we have explored, and this is gallium 68 FAPI, which is giving good images, and when it came, it was thought that it will replace glucose because it is taking all the lesions and there is no physiological uptake in brain. So it is a very good molecule, but it never happened. FDG is still in demand. So these are two images I have shown that generally in hepatocellular carcinoma there is no uptake of FDG. But here also in one case there is a very good uptake of FDG, and in second case it is only the capsule, the outline is taking the FAPI. So this again this is showing, and where the in FDG it is taking highly taken up by the lesion. So there that is why it is important to do first diagnostic scan and then go for the therapy. So that is called the personalized medicine. So this patient we have, this is the ACC patient which we have, there is a new peptide which is equivalent to the inhibitor. So it is also taken up by, it is also targeting the FAP, the fibroblast activation protein, and we have treated this patient, we have given 2 cycles, and this patient is really benefited. Now coming to my own research, it is not my own research, but the students' research basically. And this work is inspired by Sir only. So he is very much fond of tamoxifen. So I have labeled, not me, my student has labeled the tamoxifen with technetium, and with this work, this molecule, which the rhenium or the technetium, this is for diagnosis and therapy also, and fortunately I got the patent for this, and we have now seen that this patient, and this the first image is the PET image, which is showing uptake in the lesion, and the second one is also the whole body image, and the red one, the hot red color is FDG, and the blue color one is tamoxifen, middle one is the PET CT image. So you will appreciate that wherever the FDG is, the tamoxifen is also taken up. So that means the quality of the radiopharmaceutical is good. And to confirm this, fortunately we gave this, and we did not get any image. You will see the blank, only the kidneys are there. So then we get back to the patient, and we have seen lot of metastatic lesions in FDG. So then patient said that she was on tamoxifen for the last 6 months. So this is again proving this tracer specificity for ER receptor. We have also explored the HER2 receptor, and we have radio labeled the trastuzumab, the whole antibody, and the fragment of the antibody. And we have seen that the affinity, the last BLI image is showing it is the KD is in nanomolar range only, though the affinity is decreased when we chop the whole antibody to the fragment, but it is still in nanomolar concentration. And we have shown it in patient also that the lutetium-177 is a long-lived isotope. It has a 7 days half-life. It gives gamma and beta both emissions. So we could image it for the longer duration, and you will appreciate the uptake in the lesions. This is because the pharmacokinetics is slow, and the PET isotopes are generally short-lived. F18 is a 120-minute half-life and 110 minutes half-life, and gallium-68 is a half-life of only 68 minutes. So it is difficult to image the whole antibody. So we chopped it and we labeled with gallium, and at 3 hours you will appreciate that it is showing the uptake at where the FDG is taken up. Then we radio-labeled this Fab with lutetium, which is a therapeutic isotope, beta emitter, lutetium-177. And we have done up to 4 days because it is difficult to call patients again, but this patient was agree. And generally the patients are very cooperative if they come. So we have taken at day 1, day 3, day 4, and you will appreciate that this is the day 4 image, and you will appreciate still the isotope is there. So this is again the work of, as I said, alone you cannot do anything. You have to collaborate, we have to converse, we have to discuss the things. So my endocrine colleague asked me, we are having the Cushing disease syndrome patients, she's actually concerned about the Cushing disease. So she said, if you can label CRH. So I did this, and I think you all are knowing that CRH is produced in hypothalamus, and in pituitary there are CRH receptors which secretes ACTH. When there is adenoma, there are hyperexpression of CRH receptors, and more ACTH production. So for ACTH dependent Cushing syndrome, we can use CRH, and we have synthesized this CRH. And again, because CRH is a big molecule, so it has slow pharmacokinetics, and there is a lot of uptake in liver. So she also then gave me the idea of labeling desmopressin, which is exclusively expressed on adenomas, but it is not present in normal pituitary. So this is the image of CRH because it is a big molecule, so there is lot of uptake in liver and spleen. It is also excreted by kidney also, but fortunately there is no other uptake, so we can localize the adenoma. And it is also for the differential whether if it is not because the CRH receptors are there in adenomas, so there is diffuse uptake even if the adenoma is not there, but there is the focal uptake when adenoma is there. So it is really helping our neurosurgeons for surgery. In some of the cases there is no lesion seen in MRI also, so they come for us. Now though it is a practice, they without CRH scan they don't do any surgery for pituitary ACTH dependent pituitary adenomas. And this is another compound, the M-desmo, and you will appreciate that there is no uptake except the excretion through the kidney. So this is also very much gaining, and for both of the molecules we are getting referrals from all over the country. So unfortunately we got 2 patents for this also. And now we have made, because we want everybody to use it, so now we have made a kit so that anybody can take this kit to the hospital and label it and use it. So next molecule what I have developed is the microspheres, which are very cost effective, as it is equivalent to Y90 thermospheres or the stereospheres. These the neutral unlabeled microspheres I have synthesized, and now they are used for similar to SIRT or the tear, and these are giving good results. The last one you can see that there is a lesion, but it is disappeared after one therapy. So we have treated almost 60 patients with this. Now the rhenium 188 is a generator produced, and generator is now availability is question mark. So during COVID also we didn't get any generator. So I shifted to lutetium-177, which is produced at Bhaba BRC. So I have labeled this, and because I have already told you that this is a long-lived isotope, but it's still and we have seen that these microspheres are taken up by the cells, whereas the Y90, these are the smaller size as compared to thyrosphere and cerosphere. So these are taken up by the cells. And it was to our surprise, we could see up to 3 months the tracer, the radioisotope was there. We called this patient for response evaluation, but I said that just put this patient under the camera, and we have seen that up to 3 months we could see the activity in the patient. So it is working as a seeds, the permanent seeds which we can put in the tumor. This is again the patch, the customized patch just told me that the therapy which is given by the radiotherapy setup, we prepare the customized patches fit to size of the this BCC, or we are also treating keloid with this non-tumorous growth, and we are making the customized patches, and in the patient who are not fit for the surgery or the radiotherapy, like near the eye, so we are treating these patients. This is the simple that the bone seeking agents are there for the bone pain palliation. As the ring is there, we are also treating the microspheres for radiation synovectomy. We are not purchasing anything. This is all in-house, synthesizing and treating the patients. So the take-home message is understand the tumor biology, explore if anything already exists, like CRH was already existed, and it is used for IPSS. So we have used already the molecule already in patient use. So we don't need to take other experiments like toxicity and all. So, and I believe in 3C: first, converse, collaborate, and contribute. So, and because we want our heterogeneous population is there, some are rich, some are poor. So for rich people, there are so many things, but for poor people, they are deprived. So cost effective made in India treatments are always good. So we need, so that what we make, everybody should eat. Everybody should use it. So there is a need for availability of ready-to-use kits. So this is my team, my students who are working all the job for me, and thank you everyone for patiently.
Thank you, Dr. Jaya, for and ever since she was doing PhD in All India Institute of Medical Sciences in Department of Nuclear Medicine with Dr. Bandyopadhyay. Dr. Rath sir, Indian anti-estrogen molecule developed in Lucknow called Centroman. Centroman was developed by Central Drug Research Institute in Lucknow, and for treatment of ER-positive cancer. Sir, if you remember, in KG Medical College, Dr. N.C. Mishra was using Centroman, which is an Indian tamoxifen. You can read Indian tamoxifen. And we have used it for benign breast disease, for breast pain, and for fibroadenoma. It's very effective. And gynecologists have used it in many functional disorders where there is increased estrogen receptor activity, like dysfunctional uterine bleeding, endometriosis, fibroid. So can you tag Centroman to some isotope, say gamma emitter for scanning, and then lutetium or beta emitter or alpha emitter for therapy?
Sure, sir, I will try.
So it will be totally made in India.
Yes, sir, I can try.
Thank you.
Thank you.
Wonderful presentation, ma'am. It was very insightful. I would like to congratulate you. You are very innovative, and I'm highly impressed with the patents that you have. So, being a breast and endocrine surgeon, I totally correlate correlate with all the images and other things, and I can understand that we both are separable from each other.
Yeah, same base.
Yeah, on the same branch. So one very important question, because the PGs and the students are also here, I would like to ask from you. And we always talk about the effects, but seldom we talks about the side effects, because we can understand these are radioactive emitters. So can you please, for the benefit of the post,
Yeah, very good question.
What is the maximum permissible dose to any individual, especially while PET scan, FDG PET scan is the most commonly prescribed investigation. So what is the radiation dose that is given to any patient when a single exposure of PET scan is being done? What is the maximum permissible dose for an individual in a year? And how judiciously should we advise for PET scan? Because I see many clinicians, especially when the cancer is a metastatic cancer, they advise 6 monthly PET scan. So how rational is this investigation?
So I would say for cancer patient, it is benefit versus risk. So if it is benefit in the patient, it is required, and you after 6 months, if the patient is progressing with the disease, so it is better to know the disease first. And as far as the dose is concerned, it is 550 microsievert per year per individual, and it is around 18 microsievert per PET scan. But for the main doses of CT dose, the PET we are using only microcuries, and the amount of the molecule, the chemical toxicity is also less, because we are using micro to nanomolar concentration. So it is not giving any pharmacological effect. But basically in nuclear medicine, the drugs which are used, which are labeled, is actually the carrier. It is a navigator. It has it navigates, and the just like the missile, the targeting the lesion. So it will deposit in the lesion only, and the rest will be either decayed or it is excreted from the kidney or what. That it is basically depends on the type of molecule, whether it is hepatobiliary clearance or the renal clearance. But because we are using in micro to nanomolar concentration, so it is not giving any pharmacological effect. And for patient, it is 18 microsievert per PET scan. The whole body, not the regional one.
Ma'am, I would like to add here that with the recent digital PET CT scan, it has been reduced to 7 to 10 microsievert per PET scan.
Yeah, so
we are using very low dose for FDG as well as the CT.
Yes. So it is the win-win situation only.
It's very nice information that you have given. The reason for my asking, in one of our presentations regarding the use of nuclear medicine in breast and endocrine, so one of the nuclear medicine physicians, according to the discussion that we had, we came to conclude that single exposure of PET scan used to give that much amount of radiation exposure which we are supposed to get in 1 year. So at least one PET scan in a year is more than sufficient. So therefore,
no. For the patient, if it is a physician, you guys can tell now if you have to repeat 6 monthly or generally generally it is yearly, but in case of suspicion only you are suggesting. So it is for the benefit of patient only.
Okay. Thank you very much, ma'am.
Okay, yeah, thank you.
Thank you, Dr. Jaya ma'am, for generously sharing your knowledge and experiences with us. Now, I would like to invite all the chairpersons to come forward and present a token of appreciation to the esteemed speaker. I would also like to invite Dr. Anil Gupta sir to felicitate the chairpersons. हाँ सर, आपको इनको करना है, द चेयरपर्सन, द फोर ऑफ देम।
अभी जाने क्या?
अभी एक बार मैम का होगा, जय मैम को उसके बाद
मुझे बता देना।
Professor Rath sir, I would like to inform you that she is also working on a new idea, which is L-glucose based scanning. So whole world, all the plants, animals, bacteria, they all eat D-glucose, which is called dextrorotatory glucose. Sister लोग इसीलिए dextrose बोलती हैं उसको. So dextrose is dextrorotatory glucose. So if you pass light on a glucose solution, the light will deviate to the right side. So in biophysics or biochemistry, they call it dextrorotatory. There is another glucose called L-glucose, levoglucose, where light will rotate to the left side. So only two cells take L-glucose, cancer cells and bacteria, some bacteria. So I have been persuading her to tag L-glucose based PET, which will be selective only for cancer cells. Usually in PET scan, sometimes we have false negative, false positive, like lymph nodes due to tuberculosis, mediastinal nodes often, or healing after surgery. So with L-glucose, it will be exclusive positive only for cancer cells or bacteria. So she is working on that. Is a very famous endocrine surgeon trained in JG Medical College with Dr. Sandeep Kumar, and then she did FCH breast and endocrine from Sanjay Gandhi Postgraduate Institute. Dr. Saloni is the chief of our medical and nuclear medicine imaging and PET scan. Thank you.
Let's move to our next topic, which is acute myeloid leukemia, update on the diagnosis, risk stratification, and the management. It will be presented by the esteemed speaker, Dr. Ranjit Kumar Sahu, who is the additional professor at AIIMS, New Delhi. This session will be chaired by Dr. Amit Ahlawat sir, Dr. Shubhangi Gupta, Dr. Bharat Sukhija, and Dr. Asya Hilal. Do you need any laptops? No. It's there. Okay, it's there. Thank you.
Can I start? Thank you.
I'll take the honor to introduce Dr. Ranjit Sahu. Dr. Ranjit Sahu is DM in medical oncology and is currently working as additional professor at AIIMS. Dr. Sahu has expertise in all sort of chemotherapy, including all the hematological malignancies, lymphomas, leukemias, with special interest in stem cell transplantation and autologous transplantation. Sir has more than 200 publications, and I think he will be the best person to speak on AML. Thank you, sir.
Thank you for the kind introduction. At the outset, I would like to thank the organizers to have invited to interact with you. And a special note goes to Dr. Anil Gupta. So, acute myeloid leukemia, this is one of the cancers. Over last 1 or 2 decades, it has gone the maximum amount of change. And I do not have any conflicts to disclose here. And this is how the acute myeloid leukemia, and as it happens in this part of the world, this could be a complicated table, but if you could concentrate on the first column, this data comes from a good leukemia center in US. It is called as MD Anderson Cancer Center. As you could see, the patients that they have treated, the age was close to 60 years. And when you look into the other data, which comes from India, 2 are from AIIMS New Delhi, 1 comes from CMC Vellore. If you look at just the age, we are at least 2 or 3 decades younger than the patients that are treated at the US. It is not because we come from a different planet. It is possible because of the population structure. In India, even in the last census, people who are more than 60 years are not even 10%, it is 9%. So most of the patients that we see in a clinic, they are in the 14 to 40 year age group. And as you could see, most of the cancer, age is the most important risk factor, and in AML as well. But in a clinic, we see much younger patients. So the other thing that I would like to all of you to focus is the induction mortality. The induction mortality means once you start these patients on treatment, how many of them are dying in the first 30 days. So if you look into MD Anderson at 60 years age, the mortality of patients are 10%. At our center, this was a data which is a decade older, from 2000 to 2010. It was close to 20%. And the data which comes from CMC Vellore, which is a little older than our data, it is close to 25% of these patients. So you could imagine acute myeloid leukemia is a curable thing in patients who are younger, but there could be a risk in the first 30 days of treatment. It means that the treatment could be causing a lot of trouble to these patients. So now those who have still remember the pathology classes, AML used to be 7 diseases as per the V.B pathological classification from M0 to M7. We don't consider M3 as an AML. It is a different issue, but it is classified under AML. But if you look at what are the types of AML as of today, these are at least 1,000 diseases. The restratification, the AMLs could be restratified into 3 types. Those who have got good risk means they are completely curable to an extent of 60%. And then intermediate and poor risk. Poor risk, the cure rates are very, very less. It is less than 10%. Intermediate is something in between, somewhere around 30%. But as of today, if you look into how do we classify AML, it is more like the genomic-based classification, where you could still improve on the prognosis and the outcome. The treatment, some 2 decades back, it used to be all or none. All means the chemotherapy that is used in AML, it used to be the most intensive chemotherapy to be used in any cancer that we treat. It is called as 3 and 7. 3 means 3 days of one chemotherapy that is called donomycin. 7 means 7 days of another chemotherapy that is RSA. This is the most intense cytotoxic treatment to be given for any cancer, I would say. So the patients will always be classified whether they would be tolerating 3 and 7 or they may not tolerate. So patients will either get treatment or they would not get treatment. That was the time. And now it is personalized. So those who are extremely fit people, they would get a proper chemotherapy that is 3 and 7. Those who are not fit, they can also be managed by some low intense chemotherapy that is called as hypomethylating agents like azacitidine. And in last 5 or 7 years, there are now some personalized drugs which are common to the forum, which can certainly make the patient's life little better, like a drug called as venetoclax, which inhibits BCL2. The other thing that comes into the AML management is the bone marrow transplantation. Now, those who are good risk AML patients, most of them would not require a bone marrow transplantation unless they relapse. Otherwise, patients who are poor risk, all of them would require bone marrow transplantation. In intermediate risk, there could be some confusion. Some might require, many might not. Now, BMT is also an intensive procedure, and it carries some mortality in the first 30 or first 1 year. And it should be given to patients who could actually tolerate the procedure, and to patients where the risk of relapse is higher unless you do it. So this comes from the Swedish registry. If I may put a word about this Swedish registry, it is one of the finest cancer registry across the world. And this is one of the analysis, as you could see. Now, the intent of treatment with something like an intense regimen like 3 and 7 with age, and these are the blocks which comes from different parts of Sweden. And when you look at less than 60 years, most of the areas in Sweden will try and treat them. When it goes to somewhere around, let's say, 80 years or above, only few regions are treating with intense treatment. So the treatment of AML could be difficult, and it should be personalized. So if you look into the outcome of AML, the two most important things are the age. While when the age is 60 or above, they are incurable malignancies unless you do procedures like BMT. But those who are younger, like let's say 18 to 40, they are much more curable. The other important thing is the performance status of the patient. The performance status means the general condition of the patient. If the patient is running, walking, on a wheelchair, on a stretcher, they are just the scores of performance status. If the performance status of the patient is bad to begin with, it is very difficult to salvage these patients with only chemotherapy. There could be an excess mortality in these cases. So as you see here, those who are young, like less than 50 years, the induction mortality is less for patients who are having a good general condition. But even when they are younger, but with a bad performance status or a bad general condition, the mortalities can increase up till 25%. So this is the regimen that I have been talking to. Many of this thing would not have been born. So this regimen, that is 3 or 7 or 7 and 3, is since 1973, and it is still considered a standard as of today. You can guess who these fours are. So when you look at the patients, I mean, this I am talking some 2 decades back. Patients who receive this intense treatment, close to 50% of these patients or 60% of these patients will go into remission. When you don't give this regimen, give them something very simpler, like low-dose Aracid. This is one of the analysis which has been done. Close to 20% would still achieve a complete remission here. The survival, even in patients, those who have received this intense treatment, it is not great. It was only 21 weeks. So, to tell you the truth, in a properly selected patient, those who are extremely fit, this 3 and 7 like chemotherapy would be the best option. The lower doses of this chemotherapy, they could be okay, but it is still, I would say, they are still toxic. So this is one drug called as 5-azacitidine. This was started in somewhere around 1980s. This is an antimetabolite, a drug similar to cytarabine, and this was actually started with an intent to replace cytarabine. But it had got a lot of neurological toxicities while the trials been conducted, so this drug was not favored. This could be a complicated picture, but this is a lab analysis This tells you when you use these drugs like decitabine, which is an RSA-like drug, antimetabolite, and the dose of decitabine, the duration of decitabine, and the methylation that it causes. Now AML, there could be higher methylation. Higher methylation means the genes are getting silenced even though the genes are not mutated. So if you decrease the methylation, these genes, they can still perform their action, and some of these AMLs can be better controlled. And when you are using chemotherapy at a very low dose, they are not cytotoxics. So they would not be injuring your normal cells. So they would be pleasurable for the patients. And in some patients where it can actually reduce the methylation, these patients could be achieving good control of their diseases. So as you see here, when you're using a lot of dose of the cytotoxic, there is no action on methylation. When you are reducing the dose of the cytotoxics to very minimal, let's say 1% of the dose we are using, then the methylation is actually decreasing. So at this point, patients who were not eligible to take your 3 and 7 like chemotherapy, intense chemotherapy, and we given this low intense treatment, very low doses of chemotherapy, we call it as hypomethylating agent and not call them as cytotoxics. These patients are actually living longer. And I can skip this part. This is our experience in patients who are not eligible for this intense chemo treatment. And when you use these low doses of chemotherapy, these patients can live up to 10 months. If you don't treat these patients, they will succumb to the illness in the first 2 or maximum 3 months. So this is the drug. It is called as venetoclax. Now we understand cancers have got some certain way of advancing itself. One of it is by evading apoptosis. They cannot undergo apoptosis. Venetoclax is a BCL2 inhibitor. Now in AML patients, the apoptosis is mainly run by BCL2. So if you use this drug called as venetoclax, this is also not intense. This is a very softer treatment. And you add it to something like the hypomethylating agents like azacitidine, it is improving survival. And if you could look the upper curve, you could see that some of these patients can actually be cured to an extent of 15 to 20% on long term. So even though you are not doing a lot of chemo in these patients and you're doing very less intense treatment with drugs like venetoclax, these patients can be cured. So these are publications in somewhere around 2010s. As I was talking about that AMLs are not those 7 or 8 types. Now AMLs are close to 1,000 or 2,000 types. These are massive next generation sequencings performed on AML patients. And this is how it looks like. Now, I am not a bioinformatician, but this is called as a circus plot. So AML could be this complex. So many AML will be having a lot of mutations, at least 3 to 4 per patient. And when you look at it, these are the common mutations. NPM1, FLT3, DNMT3A. These are jargons, but this could be useful to know that when a patient is having these mutations, they might actually predict or tell you something different. So when you look into the older days of classifying patients based on the chromosomal abnormalities, let's say favorable cohort is only 19%, and these patients are living just 58% at 3 years. When you include this mutational analysis into it, they can identify the patients in a lot better manner. And as I could say, just these favorable patients, those who are living 58% in that era, they are living almost 85% if you select them based on the genomics. So genomics, as of today, is a bare necessity in classifying AML patients. So most of these AML patients should undergo this sort of testing, just to identify how good or how bad these patients are. So I will skip these things. Basically, rapidly I will run through it. Patients who are good risk, they are curable to an extent of 70 to 80%. So The CBF cytogenetic translocations means AML can be having some translocations like translocation between 8-21 or translocations between 16 and 16. These patients are very nice, and these patients undergo a better remission with intense chemotherapy should they be able to receive it. And these patients are curable without something like bone marrow transplantation. And those who are intermediate risk, it is still not very clear whether BMT is really required in such cases. And chemotherapy could be enough in a fraction of these patients. But those who are poor risk patients, these patients, after achievement of complete remission, they should undergo BMT. So these are the improvements that had happened in the last decade in AML. Now we understand the disease a lot better, and now we have got better drugs. There are better immunotherapies like antibody drug conjugates, like zemtuzumab ozogamycin, which targets the CD33. The drugs I have already told about venetoclax. We have discussed about the FLT3 mutation. Now patients who have got AML FLT3 mutation, now you have got an inhibitor. And then the hypomethylating agents. Now hypomethylating agents could be important because it doesn't produce as much toxicity as your cytotoxics used to produce. So these are the favorable risk as of today. Patients who are having 821 inversion 16 or this NPM1 mutation. NPM1 mutation had been a revelation in this era. And patients who are having another mutation called as SEPA. As of today, in 2022, those patients who are not good risk but intermediate risk, they are either the FLT3 mutations or some other translocations like 911. The poor risk patients as well, I mean, as of today, normally we used to define poor risk those who are having multiple chromosomal abnormalities when there are 3 or 5 or more. These translocations are now recently described, those who are having 6 to 9 translocation involving chromosome 11, and there are many more. And there are certain mutations. When you do an NGS in such cases, there are certain mutations like this A mutation, ASXL1B, there are certain else. And the other mutation which is too bad is TP53 mutation. You would have learnt it from some other talks. So there could be patients of AML whom you are classifying as good risk to start with, and after you give treatment to those patients, you should also be able to monitor these patients. Those who are good risk to start with, if after treatment those mutations or cytogenetic abnormalities or the rearrangements are declining to a good extent, let's say log3 reductions, they are the patients who are curable with only chemotherapy. Where it is not achievable, it is very difficult to cure such cases. So I will skip most of them. So in all these curves, I am trying to make out a point that the AMLs who were, previously described as good risk, with the advent of genomics, they can be reclassified into poor risk or intermediate risk. I will skip them, just for the sake of time. So, the question is, can we improve on the present chemotherapies? Venetoclax is actually added with the low intense treatment, but it can also be added to the high intense treatments. And it might cure few more patients. I will skip it, I will just go to the take home. So, it is very important as of today to identify the AML patients properly. And the re-stratification should be performed at the baseline. And the bare minimum as of today is to do one next generation sequencing looking at both DNAs as well as the RNAs. And at baseline, this patient can be classified as favorable or intermediate or poor. But the favorable risk patients would remain favorable only when they achieve adequate response to the treatment. Now, personalization of AML treatment is the key in this era. we have to personalize based on whether the patient will receive chemotherapy or will receive less intense chemotherapy. Both these patients are curable as of today. And whether they are only curable with just chemotherapy or they would require bone marrow transplantation in addition. And there are other targeted treatments which can also be incorporated into the chemotherapies. I have missed those slides, like a FLT3 inhibitor. So AML treatment has evolved just like blood transfusion. Now you need not, you just have to do the proper blood type and transfuse the patient, the same thing. So this is called as personalized medicine. So AML is the new frontier where personalized medicine can be practiced very nicely. That would be my last word. I will be happy to answer a few questions if you have.
Thank you, sir. It was in a short span of time, you have very well elucidated and elaborated on the treatment part of this newer treatment classification of AML. Being a pathologist, I like to add now FAB classification, sir, has been reduced to only UG teaching. Nowadays, WHO classification and even ICC, International Consensus classification has been followed. And as you very well know, it has been in the genetic differentiation is the basis now.
Absolutely.
Even the threshold for 20% blast has been reduced in many categories now.
Yes.
Only. Sir, I have a question. Then what is the best possible for minimal residual disease? What is the best possible method to detect it and to what is the therapy for that?
Okay. So first start with the cytology. Normally AML is a bone marrow disease, and after giving treatment we would do a repeat bone marrow. Thank you for that photograph. That is 1 week old. Yeah. So we tap the bone marrow to see the blasts, the number of blasts, and AML we call it when it is more than 20%, and there are some exceptions as well. And so in a cytology, when the blast percentage are less than 5%, that is the time when we call it as this is a cytological complete remission. Now, why it is 5%? Because if you ask 3 pathologists, some might say it is 3, some might say it is 4, some might say it is 5. That is the reason why we call 5% or less should be cytological complete remission. Now we have got newer techniques like flow cytometry, which can identify the blast to an extent of 1 into 10 to the power -4. So that is a far better way of understanding this blast. Now the technicality of AML is understanding it. Now AML, in a classical teaching, we always teach our students that a cancer is a monoclonal issue. Now in the era of genomics, it is actually monoclonal by a certain extent, but they are having multiple clones. So when you, let's say an AML patient is having A, B, C, D, and when you treat, the ABC they goes off and the D starts to progress. Okay,
personalized medicine is now the key for it.
So you can detect the MRD technique by flow cytometry. Flow cytometry cannot be standardized as well as it is standardized in another acute leukemia like acute lymphoblastic leukemia. But you could look into the mutations and rearrangements. In AML, at least, those who are having 821 or inversion 16, you could monitor them well. If after 2 cycles of chemotherapy, they are achieving a reduction in this rearrangement, because rearrangement is the first thing to happen. If the rearrangement is at a minimal state, you definitely call it as MRD negativity. You can actually look into some mutations like NPM1 mutation. NPM1 is a stable mutation.
It has a favorable prognosis, I guess.
Yes. So NPM1 mutation, when it declines to a very minimal state, let's say 10 to the power -3, -4, you are also very comfortable to say that the AML is in a very minimal residual disease state. But despite achieving a minimal state, 10 to 20% of them, they actually relapse. So this is just a standpoint. You have to monitor them to actually call it. They should be durable. The MRDs should be durable to call them that these are the real MRDs.
My basic question then how to stop this relapse, or is there any newer modality by which this relapse of MRDs can be reduced?
So the relapses are mainly by immunological escape. Either you monitor them or you treat them properly. You have to understand the risk initially. You first give cytotoxic treatment and then you do BMT. BMT is sort of like you are changing the immune system of a patient. So if you are choosing a proper donor and doing a bone marrow transplantation, these patients can be cured more than the cytotoxics only. As of today, cancer is cured by two ways, chemotherapy and immunotherapy. If you are using both, there is a higher chance of cure. But is that absolutely make them cancer free? That is a difficult question.
Thank you, sir.
I must sir for the very lucid presentation. Actually, I am an enatologist, so I just wanted to know, like every day so many recent advancements are happening. And my question is not specific to AML. I just wanted to know whether are you using cord stem cell for any of your oncology needs in adults? Is there any role of cord stem cells?
So in adults, you could use a cord blood. The problem with a cord blood bone marrow transplantation is the stem cell dose. Normally, we require somewhere around 2 million stem cell dose for an adequate recovery. When you're using a cord source, the stem cell dose is reduced by 1/10. It will be somewhere around 0.1 or even less million for an adult patients. But for pediatric patients who are, some 5-10 kgs, we could use this cord bloods really well. And now there are technologies where you could increase the cord blood stem cells. There are some protocols where you are giving them conditioned medias. So the cord blood stem cells, they are increasing by 1 log or 2 logs. This could be used in even adult patients. Because bone marrow transplantation, as of today, everyone has a donor. You need not have just a matched sibling donor. Matched sibling means those who have got HLAs matched between patients and donors. You don't require that. Even at half matched, like a father or a mother, maybe your children, they could also be your donors, and these transplants are safe. So cord bloods are still used.
There is some role, like should we encourage cord blood banking or should it not? Like till now, are you using it at your center? My question is
yes.
So answer is yes, you are using it. It is of some use at least. But like in near future, do we have a hope? Like should we encourage parents or not?
Yes, we should encourage parents, but they should know why they are storing it.
Okay.
Yeah.
Public storage.
Yeah.
Storage.
Yes.
What you are doing is for the personal use.
Absolutely. So they should understand. They should understand why they are doing it.
There is actually a need of cord, right? We can really treat probably many more patients if we have a cord blood. America is doing at least few percentage, 5-10% of their transplant is cord blood. So we have to encourage, but we should take an undertaking on day one that if it matches someone, it should be used. If we do that, then it's worth it.
How to encourage? Like how can we go?
I don't know.
About it?
All of us have to sit together and think about it. Because when I donate a blood, I don't ask whom is it going for. Same thing should happen with the cord blood. If that happens, and fortunately we've got a very good government health system and a government delivery system. So you can actually create a good blood bank if we all of us together as oncologists, hematologists create a noise and convince the government that this needs to be stored. I think it's doable because it's not that costly.
Okay, thank you, sir.
It is about much more uses beyond the stem cell transplant. Cord bloods are very important. Thank you.
Thank you, sir.
Okay.
Thank you, Dr. Ranjit. Your insights delivered with clarity and enthusiasm were both enlightening and inspiring. Ladies and gentlemen, now I would like to invite all the chairpersons to come forward and present a token of appreciation to Dr. Ranjit. Along with that, I would like to invite Dr. D.N. Sharma sir on the stage to felicitate the chairpersons. Dr. D.N. Sharma sir to felicitate the chairpersons. We कर लेंगे. Now moving on to the next panel discussion, which is paradigm shift in the cancer care case scenarios, which will be moderated by Dr. Ritik Bansal. Promises to be a thought-provoking exchange of ideas featuring distinguished panelists from various renowned institutes. And I would like to invite on the stage Dr. Sunil Kumar Saini, Dr. Dinesh Pendharkar, Dr. Rishabh Kumar, Dr. Aruj Dihani, Dr. Faraz Badar, and Dr. Aman Rastogi.
A very good evening to everyone. Coming to our next session, we'll be having a panel discussion trying to we all know that from 80s till date, there is a gross change in tumor biology understanding as well as the plan of management, how we deal with our patients today. Instead of a blanket treatment, it's more of a personalized treatment for every patient we come across in our OPD now. Just to highlight the paradigm shift in cancer care, a famous saying that tumor biology is the king, patient selection is the queen, and technical procedures are the princes of the kingdom. Only rarely can the prince usurp the kingdom. Basically, they all walk hand in hand. One cannot overtake the other one. So starting with the first case scenario, here is a 65-year-old retired army personnel presented with complaints of bleeding per rectum since 4 to 5 months. He gives history of weight loss and loss of appetite. However, there were no significant changes in the bowel and bladder habits. Neither were there any features of impending bowel obstruction. On examination, digital rectal examination, per abdomen was normal, but on digital examination, there is a lesion fell from 10 to 4 o'clock position with approximately 60% compromise of the lumen and lower edge at 3 centimeters from anal verge. Proximal edge could not be felt. Yolk mason stage 3. Also, there is non-significant family history. Patient underwent colonoscopic evaluation, which was a complete colonoscopy, no other synchronous lesions, and detected a lesion in the distal rectum, which was reported to be moderately differentiated adeno-CA, and serum CA levels were 8.2. The contrast enhanced MRI was in favor of T3N1 kind of picture. Metastatic workup was done, which was negative. So with this, I would like to direct the first question to Dinesh sir. Sir, any additional information before proceeding with treatment planning in this non-metastatic locally advanced rectal cancer?
I would not really like to have any information, but what I would really like to have is a good opinion from my surgical and a radiation team before I decide what I want. If I have a capacity, I definitely need biopsy. I would like to do NGS markers and immunomarkers on day one. That's my policy. If patient affording, but not affording, my policy is very clear. Opinion from a surgeon and a radiotherapist before I decide the next plan.
So, proficient MMR or MSS stable, or else deficient MR was in MSI high. Any comments upon that, Dr. Aman? Can we have extra mic, please, on the list?
Thank you.
So this we are getting it tested or what?
No, patient, we have to give options to the patients, and he asked what is the current paradigm shift that we have seen over the last few years, why we are going molecular.
Definitely, because it has led to changes in the management, that some cancers which are more sensitive to the chemotherapy, some are not. So that's why the importance of MSI have definitely come in the practice, and we should actually follow this.
So sorry for this busy slide, but there have been multiple trials and studies, though the limited patient number, in which even in the MMR proficient rectal cancer, when adding immunotherapeutic agent in patients who had MMR proficient backup, the response rate was better. Similarly, a patient with deficient MMR, which are known to be more sensitive to the neoadjuvant chemotherapy as well as immunotherapy. One of the significant studies were the patient sample size only 14 is by Kersek et al., in which he used dostarlimab for 6 months and there was almost 100% clinical response. Seni sir, this is for you. So your institutional protocol versus current evidence-based medicine treatment options.
Well, I can tell as a surgeon, adequate workup has been done for this patient. And definitely I would refer this patient to my medical and radiation oncology colleagues.
You will opt for a neoadjuvant treatment.
Neoadjuvant therapies, whatever they may be, depending on all these studies.
So what's your comment upon TNT, sir?
Well, it's whenever suitable patients.
Whenever suitable. So in this patient who is a well-informed, educated, 65, knows about the possibility of loss of sphincter function, we would give him option of TNT. But with the underline of what cons you will highlight for that patient, sir?
TNT, yes, but whether in sphincter preservation, that's may not be feasible because in the lower rectum, in spite of whatever neoadjuvant therapies he receives, still after completion may be recommended to undergo APR.
So for our audience, there have been 2 landmark studies, Rapido and Prodigy trials, which have used short course as well as long course RT, and they have seen that the disease-free survival was almost equivalent in patients who had, was better in patients who had a TNT treatment. Please, yes, sir.
I just want to make a short comment here. This patient actually appears to be CT3N1.
Yes.
So we would like to have more information from the MRI regarding the high-risk features, like the CRM and EMVI. Because before offering TNT, we need to understand that the Rapido trials, the inclusion criteria was not exactly what was mentioned in this particular case. And none of the TNT cases, if this patient turned out to be CRM safe or CRM negative or EMVI not there, then this does not actually add under the high-risk protocol. So TNT might not be suitable for this well-educated patient if we are considering CT3N1. But yes, if high-risk features are there, then other possibilities are there. But still, as you said, maybe this tell more because the Rapido had a stringent and a more, beyond stage. So maybe we can get more information from the patient.
And same question to you, sir. Wait and watch. If the patient asks after TNT, wait and watch, is it still a myth or are we following it?
So wait and watch has been in a randomized trial mainly studied, I may be wrong, but it is mainly studied in the Opera trial where you have given long course and at least 8 cycles of Capox where you have been given the option to wait and watch. Others, they did not actively study the wait and watch policy. At our institute, we are able to, we generally follow the Opera trial for the patients who are having high risk and who desire some kind of functional sphincter
organ preservation. Dr. Faraz.
I would like to add my comments from where he has left. Firstly, wait and watch is not a myth. we have got a protocolized IWWD database in which our data and perhaps AIMS also is a member institution. So we are getting not randomized, not phase 3, but the data is accumulating firstly. Second, but as far as this particular case is concerned, this is not a good case, I think, for wait and watch because it is a low distal rectal tumor, maybe probably involvement of sphincters, and I think this should not go to IWWD or wait and watch. So I will, if I treat this patient, I will treat this patient in a conventional manner, like neoadjuvant radiation, not TNT, neoadjuvant radiation.
With the high risk features?
I'll bring up the, irrespective of the high risk, with the information that I have, I will go for, I will bring up the surgery and then chemotherapy can wait later on, the way we do it. The only thing that I will do with the addition of the risk factors that are mentioned is, we can intensify the chemotherapy in between the waiting period of radiation and surgery. This is what we normally do. Probably 2 cycles of Folfox in the waiting period, the 6 to 8 weeks waiting period that we normally have. Thank you.
Yes, Dr. Man.
So basically, the advantages of TNT have been the more patient compliance.
Yes,
so it is
exactly.
kind of more patient friendly, or you can say that it's because compliant, because once the patient is treated by surgery, he or she thinks that I am free of disease, now I don't need to take any treatment. Yes. So that was the main concern. Also, we looked upon the DFS also, disease-free survival, as well as in OPRA, it's still in baby stage, the results came and they actually said that local recurrence rates are more or less same.
Almost same, yeah, DFS of 3 years is almost same.
Is almost same. So let's see, if the long-term results are same, then it actually will not be a myth anymore.
Sunil sir, you are talking about patients coming to Ayushman, most of them gaining treatment from there. With these kind of patients who require regular follow-up, every 3 monthly, ideally checkup, what is your belief in?
Like, so a patient who has complete clinical response based on clinical and imaging, well, we won't promote it, but we won't promote wait and watch.
Yes, sir.
But we would agree to the patient if patient insists on that, okay? And or for some reason, if a patient is not suitable for colostomy or like difficulties in self-care, less social support, so maybe we may agree more easily with him, okay? But warning him that this is not the routine to do, okay? And keep him under a close observation.
So like we discussed on the OPERA trial, 3-year DFS was 76% for the induction chemo followed by a CRT group and 76% for the concurrent CRT followed by consolidation chemo. And patients who underwent TME after restaging and patients who underwent TME after regrowth had similar DFS. Any other comments for the previous case, or shall we move on to the next?
So my plea is, if from practical actually point of view,
yes,
when a patient comes like this, rather than taking time in taking decisions, let's put this patient on chemo. Let it start as early as possible, within a week of patient coming to you, and you have all the time to discuss between ourselves, find out other data, think whether he can do genomics and all that. Not waste time, because if we start talking, discussing between the thing, majority of the patient with rectum will always go to a second third, fourth institution.
Yes.
That institution may not be better. If he has come to you, probably yours is the best institution for him. Otherwise, he wouldn't have come to you primarily. So I think we should try to hold the patient, initiate the treatment. The moment we initiate treatment, he gains at least some confidence. And all of them respond post-chemo. So the moment there is some response, they gain confidence in you and in your system, and you can retain them probably better. So I think initiation of treatment as early should be the key. And all these trials are okay, they are fine.
That like how do we go about induction chemotherapy versus consolidation chemotherapy, which has come up in a big way, like giving NACTRT followed by chemo or chemo followed by NACTRT, which should be
There is no big data. All these trials, let me tell you frankly, when you sit with these doctors one-to-one, in last 10-15 years, I never heard any American physician telling me I do not start with chemo. It's a dictum, whatever they write here or do, even if you read the data in detail, there are always a two group, starting with radio, starting with chemo. Actually, it depends, जिसकी लाठी उसकी भैंस. अगर वो रेडियोथेरेपिस्ट के पास पहले पहुंच गया, he will put on radiation, वो कीमो के पास पहुंच गया तो कीमो. This is a reality, but in true sense, in America, chemotherapists are in superpower. Majority of them would start with chemo.
Sir, I would like to add to what sir was saying. Just 1 minute. There is a historical background to this. The idea behind starting radiation first was to bring up the local treatment before, because at the time when TME surgery was started in 80s, the main failure was local failure. So the emphasis was on to protect the local recurrence. And nowadays the whole shift has whole focus is on the distant recurrences, that and only chemo will be doing that. So I do not completely disagree with sir. If we can start with chemo early and retain the patient, that will be in the best benefit of the patient. Thank you.
To add to that, it's sir's opinion that ARO12 trial, though the pathological response rate was better when it was concurrent compared to induction, but in terms of reciprocating in disease-free survival and overall 5-year local recurrence rates, there was not loss to treatment or delayed in treatment. Coming to the second case, 63-year-old postmenopausal female with history of comorbidities of diabetes and hypertension, which is patient is compliant and controlled, present with abnormal uterine bleeding. These were the MRI cuts taken, and biopsy was reported to be, which is shown to be well confined to the uterus, looks like more of a 1A or maximum like little bit 1B category in the lower segment. Biopsy was reported to be grade 1 endometrioid adenocarcinoma. Staging workup for regional and distant mets were negative, and patient was advised surgery up front. So, Sani sir, your approach for surgical cases in endometrium, limited the uterus, 1A or 1B, low grade.
Well, I would still go ahead with radical hysterectomy with TAH, BSO, and pelvic lymphadenectomy.
You will go for a minimal accessor or open approach? This one?
Well, that depends on local expertise available with local team. I would say surgery, yes, whatever it may be. And as far as surgery, I would open would be preferred.
Preferably open, sir. Any contradictions to that, Aman? Means, what is your opinion for this open versus
grade 1 or with 1A kind of disease, we can still go with laparoscopy because the surgical challenges are low and chances of getting positive parametrial or some margins like that are very less.
Yes.
And definitely we won't be needing an omentectomy in this kind of a case scenario for the staging purpose.
I think Dinesh sir was eager to add something to it.
Say, I'm a surgical medical oncologist and I believe in big surgery. See, there are so many ifs and buts. We don't know nodes are there, we don't know nodes were not there. If they go with a smaller surgery, we don't know whether they will be able to. It's good for a fashion. Because you actually have to see everything to get a confidence. Not that it's not 1A, 1B, I don't say MRI is wrong, but still, after all, it's a curable disease. So the first attempt, if it is wider, I don't think there is any much surgical problem doing laparoscopy versus... Generally, surgical oncologists are good in doing good surgery.
Similarly, the trials also favor the same. There is no difference in the local, regional or DFS or overall survival. It depends upon, like sir told, primary is oncological control. Secondary is the expertise. If it's available, well and good. Otherwise, as per the patient.
My actually humble request to all oncologists, please discourage laparoscopic surgeries and even robotic surgeries. It's good. I don't say it's bad. But unfortunately, we are talking of advanced disease. We are not talking of patients not coming in time. We are talking of patients not following. At least we'll be more confident when even if patient doesn't come up, there's nothing inside.
Aman, you were smiling on that about minimal access. No, I am a surgeon, but I am with sir because I have done my MCH with Dr. M. Vijay Kumar sir. He will always say, open and see. Laparoscopy, if in very good hands, try it.
Even in Tata, sir, of course, the consultants were always in the favor of open surgeries. Definitely, sir. So, I'll agree. No doubt.
I approve. I'm not a surgeon, but I approve of a laparoscopic surgeon who has a very good experience.
Very good at
Open surgery.
Yes, yes.
Yeah, definitely, sir. Definitely.
Sir, any comment upon peritoneal cytology? Is it still worth doing in C endometrium, especially if it's suspected early stage malignancies? Peritoneal cytology. On table.
Endometrial, I don't think it's required.
No.
But if a surgeon goes in, feels there is some nodule, I think he can always do. But I don't think it's justified in endometrial.
Not a part of staging also now?
No.
But prognostic values, if there is no obvious disease, means there is no suspicious thing.
I'm not aware of any data, but generally these patients do well with this disease.
This one is for my radiation oncologist friends. Lymphadenectomy, should we do? We means the surgeons or leave it to our radiation people?
I think right now you can leave it first to the surgeons right now because there has always been a controversy. Some people want to take out the lymph nodes, some people do not want to. So best to leave them out and let the surgeon decide that.
If they are grossly enlarged lymph nodes on table, you see at common pelvic or this thing, but para-aortic is not palpable or not seen in the imaging also. What's your call? Would you like to still go ahead with this thing, formal lymph node dissection?
I will be happy to get a patient with complete surgical staging. That is how I want it. No lymph node dissection, no staging.
No, my question is it should be systematic lymphadenectomy or just a berry picking of suspicious nodes or a sampling basically? I'm not going to the sentinel lymph node.
I think stage 1A we are talking about.
1A, 1B, yes.
We can leave this lymphadenectomy in early stage. This is what my opinion is.
So definitely, if we are not seeing any clinical lymph nodes on a scan, that's why we are going inside directly. Getting a node, suspicious node, if you are thinking, then definitely we can get that node so as to stage the patient better.
Stage the patient.
So we need to stage the patient better so that it becomes easy for the radiation people also for future treatments.
Basically a staging procedure than a therapeutic procedure for the patient.
Sampling is the answer.
Sampling is the answer. Berry picking or sampling is the answer. Okay, are we practicing this thing, sir, in any of institutions? In Meerut, it's very, I don't think anyone is practicing as far as I know. Sentinel lymph node biopsy in C endometrium. No experience in that, sir?
I don't think anybody is doing.
No worries. It is, it is the next hot topic for. Yes. That's the answer to the systemic lymph node. Maybe we can go for a sentinel lymph node biopsies. Less morbidity, better accuracy. Sensitivity is also good with a dual dye technique or even a single dye technique.
I think if the readers are available, then it will be easy to do.
Yes.
Because at least you need some marker.
Yes. Sorry for all these busy slides. It was for, I felt some audience might be interested in knowing the trials. We read day and night to pass our MCH exams or DM exams. That's why. Okay, this patient finally underwent surgery and the CAP protocol was for total, and the surgeon wanted to do open surgery as well as bilateral pelvic systematic lymph node dissection, and he did peritoneal washing. Might be my kind of guy who would prefer to go thorough. So the tumor site was endometrium, tumor size was 4 centimeters, histologic type was endometrioid carcinoma, NOS type, and grade 3 reported on the final histopathology, and it was 1B with more than 50% myometrial invasion and focal LVSI. Lymph nodes were negative, not even a micro metastasis was seen. So finally it is stage 1B. What adjuvant therapy would you like to offer, or you would like to further try to gain some information before planning for adjuvant treatment. Dinesh is ready to answer about the question, I guess.
I'm not ready to answer. Unfortunate. I've got some fixed ideas which don't fall into science. I would have sent this patient for radiation. That's so.
Okay,
whether I like it, whether data, no data, my patient goes for radiation. If at all radiotherapist feels no radiotherapy, let him write no radiotherapy. But I would definitely send for radiation.
Sir, what's your opinion, sir?
So this patient will require radiation, and the choice of radiation, I mean, the focal LVSI positive will throw a certain comment here. Otherwise, if it was extensive LVSI, we would go for EBRT. And focal LVSI, right now, we're not getting enough data to recommend EBRT, so we can go with vaginal brachytherapy. But school of thought here, like in India, I mean, if you look at endometrial carcinoma, normally the practice is if you're giving EBRT, we would go ahead with the vaginal brachytherapy boost. Yes. But in none of the randomized trials, actually the vaginal brachytherapy boost was involved. So right now, only with the lower uterine segment involvement, we are generally pushing for VBT. But in our practice, we are normally giving brachy boost with EBRT if that is it. But in this case, vaginal brachy should be.
Since the topic for our discussion is paradigm shift, so any comments upon molecular classification in planning adjuvant?
Adding on to what my colleague has just said, as far as paradigm shift is concerned, we would also like to get a molecular profile for this particular patient because in endometrial cancer, the molecular classification has come up in a big way. We have covered that path of therapeutic importance, of diagnostic importance of molecular classification, and we are just in the era of entering the therapeutic impacts of molecular classification. This is one site where a molecular profile besides lung, etc., where it was already there. So in the recent times, treating, although I 100% agree with the treatment part, but still I would like to see whether this patient falls into the favorable molecular risk group or unfavorable type, the 4 types that we all know, POL, ultra-mutated, that just to say the most favorable type. Although, just to emphasize that at this point of time, today, that will not impact my treatment decision as far as treatment is concerned. I will still go for EBRT, followed by intravaginal brachytherapy as summarized. Thank you.
Any comments upon European versus Australian physicians? How would they like to opt for either of them? Means they would go for a more of a radical treatment or a conservative treatment? So like you would like to answer, sir? Okay, conventionally it was grade 3, so ideally should go for a EBRT and or vaginal brachy, like Dr. Shiv told, and but with the advent of this molecular genomic atlas and molecular classification, the POL mutated has shown yes, Suman, you would like to add?
So I would like to say, like in IHC if we get an IHC of this cancer, we'll get an idea of about MSI and as well as P53.
Yes.
The problem lies with the POL mutations because that you can't identify in IHCs. For that you need to get a PCR. So if we don't get any of these, then we can likely think of that it's a POL mutation, it's a better variant. But still, if it turns out to be P53, then there is a problem whether we should give only radiotherapy or we should combine with chemotherapy.
Chemotherapy as well.
So that is of my concern, like should we, if the P53 positive, so what should we do about in this case?
So as you've rightly pointed out, I mean, generally the retrospective data has shown that the addition of chemotherapy tend to do better with the P53 mutation. But the only thing is, right now the ESMO includes the molecular classification, and the Europeans have actually included in their in prognostication. Americans right now they are still behind. The point is that we don't have randomized data right now, but the trials are happening in after stratification that this is what is going to be the adjuvant treatment. But right now I don't think so the data is mature enough to give chemotherapy or concurrent chemotherapy in a stage 1B endometrial cancer, even if it's grade 3. And on the other hand, if it's a pole mutation, I mean, I don't think so anybody would say let's not give treatment because it's pole mutation in a stage 1B treatment. So we can do it for prognosis, but for me, I mean,
for your peace of mind, your sleep.
No, I mean, I would not really bother for my peace of sleep also, because I know even if I do or not do, if I'm going to do the same thing, so I don't find any rationale to ask the patient to spend this money and do it. Till the time I feel that there is a test which can actually change my course of management, I personally would not ask for molecular tests right now. But if the patient, but I would obviously tell them, that this is what is the paradigm shift in terms of prognostication. If you're happy that I can tell you that this is going to be your prognosis, if you're okay with that, then we can ask the patient to spend money. But if it's not going to really change the course of management, I would not really push them to do for the molecular classification.
Just one line. We have discussed this. There is a question of P53. Hello. In endometrium, if we have got a P53 mutation, and if we see the whole the cancer genomic atlas data, almost all, a majority of P53 mutations, they fall in copy number high. That is the most worst prognosis group. So I will, even in this group, I will perhaps differ, maybe people will differ, but I will add chemotherapy if we have got a P53 mutation, because that correlates with the worst survival. Even in the molecular classification has correlated with that thing. Obviously, as my colleague has just mentioned, that we do not have all the IHC markers for that, but if P53 is coming, then it is
indication for go little aggressively for the patient.
Yes, I will get aggressive.
So this was by in International Gynecological Cancer in 2020, where they have stratified as a low risk when the molecular classification has come into play, and in stage 1 and stage 2, pole mutations have come under low risk. The impact of this has been studied in PROTECT 3 trial. In fact, PROTECT 4 is on this thing. Interim analysis is going on that might give us a better outcome. But what PROTECT 3 portrayed was that if it's a pole mutation, additional treatment with in endometrial carcinoma, it was not significant if you add chemo to it, even in a grade 3 disease. So this is from the ESGO-ASTRO guidelines. That's why I mentioned that European versus Americans, they try to fight over English as well as over treatment. So if it is a stage 2, like in our case, if it is pole mutated, they propagate, no further treatment. But stage 2, I'm talking about stage 1B in grade 3. But even in stage 1B in grade 3, if it is stage 1 or stage 2 with pole mutation, not just stage 2, stage 1 or stage 2 pole mutation, they are going little more conservative. They say less is more in that. Okay, coming to the third case, a very common scenario, the oral malignancies in our Indian setup. A 47-year-old male patient, pawn shop owner, presented with lesion, which you can see in the left buccal mucosa extending onto the left GB sulcus. Patient had OSMF on this thing, examination as well as grade 1 trismus, no clinically palpable nodes and no known comorbidities. Biopsy was reported to be moderated differential squamous cell carcinoma, and CCT was evaluated before referring to a center with 3.3 into 4 centimeter lesion depicting enhancement on contrast and epicentered left buccal mucosa extending into the GB sulcus. Lesion is abutting but not eroding the mandibular arch. However, the height of the lesion is significant in this one, and there were few subcentimetric ipsilateral level 1V which were correlated ultrasound and looks like more of inflammatory or reactionary nodes. Thorax study was normal. So likely plan for treatment. Aman, our daily bread and butter.
So basically you have tried to make it a T2N0 case.
T2N0, yeah.
But the thing is, key patient is having trismus, so I feel that trismus upstages it a little bit because might be medial pterygoid involvement or something like that can be.
But imaging, it is all restricted to the buccal mucosa and GB, not going to the ITF and all.
So definitely the CENT trial has come up with that. If we do a sentinel lymph node biopsy.
No, we are talking about the primary tumor. We'll go to the nodes in the next question.
That is surgery.
Upfront surgery.
Upfront surgery.
No doubt about it. What will be your surgery in this one? What will be the resection other than the tumor and margin?
Composite resection. It will be a bite composite resection as the diseases involving the upper GBS.
No, upper is free.
Upper is free.
Upper is totally free.
Okay.
Even RMT is free posteriorly.
Okay. So mostly it will be a posterior segmental mandibulectomy with
segmental mandibulectomy.
Okay. Definitely.
So is it eroding mandibular?
It's not eroding. It's abutting but not eroding.
It is written wrongly written, but
sorry, my fault. This typological error. It's abutting but not eroding. Sorry for that. So, any difference of opinions in that, sir? Saini, sir?
Actually, I'm not getting what do you mean by abutting or eroding? I would have a closer look clinically to see whether it's just...
So clinically bone appears to be free both clinically as well as radiologically. There is no breach in the periosteum or any erosion over the bones.
But it seems it's going to the gingiva and the alveolus. Okay. Then it's a segmental mandibulectomy.
Segmental mandibulectomy. Any comments upon marginal mandibulectomy or maybe any anterior chemotherapy to that?
Well, looking at the picture, it seems to be, it's a bulky lesion and it seems it's reaching to the alveolus. May not be invading the bone, but it may certainly be going in between the teeth, and it may be difficult to say whether just marginal would suffice. I won't take a chance. I would rather do a segmented mandibulectomy and plus maybe MRND3.
Marginal or segmental? Yeah. Free.
I feel segmental will be a better option. Segmental mandibulectomy.
What is the current role, Dinesh sir, for organ preservation in this kind of patients if we want to avoid segmental?
No, my personal feeling is
go radical.
Patient doesn't enter my room.
Okay.
He has to go to surgeon. And then, depending on what my surgeon says, I am very clear.
Sir, also, even if we give NACT in such kind of early tumors, margin will not change.
Yes, sir. So the consensus is basically go for upfront surgery, preferably segmental, avoid marginal, avoid any kind of anterior chemotherapy for, okay. Then the next question goes waste, okay. What about neck? Clinically and radiologically and zero. How will you like to proceed, sir? Saini, sir? You'll go for formal dissection.
I would still go ahead and do MRND3. It's not, it doesn't fit into where I could do just supramoid and I could get away with simple.
Any difference opinion in that? With a T2 kind of lesion with clinico-radiologically N0. Now I'm talking about sentinel. Aman, you wanted to add on that?
So don't have any idea about sentinel as such because we haven't practiced. Even in TMH also we used to practice this. We go with the elective node dissection, we go with the supramoid kind of neck dissection, we send it for frozen and see for the nodes. So based on that we do a comprehensive otherwise.
Okay. So which nodes are you looking upon in buccal mucosa? Means to complete it from SOND to ESOND or MRN type 3?
So basically 1A, 1B, 2, 2A, 2B.
Okay. And 3. Only means you send all 3 sets of notes for, if any of them is positive, you will convert to?
Yes, so coming up is the data that even the 2B nodes can be positive, but based on the positivity of, sometimes send it separately for the frozen to get an idea whether we need to clear the 2B or not because of spinal accessory nerve injuries and all regarding that morbidity.
Saini sir, with your experience, do you think it is important to avoid 2B? The data is now coming up to not to touch 2B if 2A is negative, or go to level 5 if 2B is negative on table, just to avoid spinal accessory nerve injury. But we'll jump to the last case after that. 2B can be avoided, sir. Any difference, or otherwise, if the suppose in the center frozen is not available, then sir? One mic, please.
Well, even if it is available, and subjecting so many nodes for frozen section is little, I would say, questionable. I would go as per the clinical findings on table. I don't use routinely to do frozen in these patients. I would still go ahead, and as far as dissecting 2B is concerned, I would look at how bulky nodes are there at the 2A level or one in the neck as such. If I find there are too many bulky nodes, I still look around in the 2B as well. If I feel it's just everything seems to be fine, I may avoid doing that.
Okay, so you would like to add one more?
See, by and large, these terms, modified radical neck dissection, etc., have disappeared from use. And the reason is very clear. The reason is now we don't know mRND type 1 is preserving SAN or IJV.
Yes, sir.
Or mRND type 2 is which 2?
Which 2?
So now we mention selective neck dissection for all.
All, yes.
One?
Yes.
Mentioning what you remove and what you spare. Correct? Between 2A and 2B, all that you have is spinal accessory, which goes places. And if you are dissecting the neck, you will know that it's very hard to differentiate the two if the two are connected.
Exactly, that's what I was trying to say.
So if 2A is positive, or even 1B is positive, it is safer to dissect out 1, 2, 3, 4. 4 plus minus, depending upon if it is tongue or, you're talking about the evidence, that's what I'm saying. Level 5 almost invariably would be spared in these cases. But in a node positive, you mentioned about frozen.
Yes.
Frozen has a sensitivity of 80% because fat doesn't freeze and you may not get an absolute report very quickly.
Yes.
We do frozen regularly. If it is positive, we complete it into SND 1 to 5, preserving SAN, IJV, and this is how we mention it now. So by and large, it's safer to err on the side of taking out 2B, preserving accessory. It's not that because you're dissecting 2B, you'll damage accessory all the time. For the same reason, 5A, 5B. That is the reason in the level 5 also, accessories to be preserved. So a lot of us tape it, and then once you tape it, you don't know which is 2A and which is 2B, to be honest, between me and you. So most of the time, you clear all two, by and large. In such a case, you would.
So I'm a physician, but I'll be always very happy, even if it's clinical N0, you dissect it.
No, as a surgeon, even if it's clinical N0, though sentinel node biopsy is coming in a big way.
But actually, worked and published, it is so many false negatives that you can put it as of now, especially in our cancer.
Yes, sir.
Secondly, there is as yet no such modality which can predict. No, is an important thing.
Yes.
So we need a dissection in these cases, which is superior. Elective, you know the Tata study.
Yes.
Elective is better than waiting and then doing it. This is the one you're talking about.
Yes.
I don't think it makes sense to believe that it will disappear on its own. It won't. And no drug is going to work on it.
Okay, in view of scarcity of time, already running late of schedule, I will switch over to last case scenario and end with it. A brief one. A 34-year-old female, mother of two, present with recurrent swelling over the left hand since past 4 months. This is the clinical picture, and there's past history of 3 surgeries over 3 to 5 years. Sorry for 3 to 5 years, and last was done 1 year back. A patient was evaluated at regional cancer center, and reports were as follows. The HP was reported as giant cell rich osteosarcoma, and the PET-CT showed a primary lesion. Along with that, few multiple nodules in the right lung numbering 4 and left lung numbering 7, mainly in the parenchyma, but away from the higher limb, and they were suggestive of active pulmonary metastasis. Previous surgeries data were also retrieved. They were all in favor of GCT. None of them were positive for malignancy. So, shall we label it M1, end of the road? Sir. In STS.
What is there in the lung?
So lung, there are 4 and 7 METs.
Now only because there had been previous surgeries. So what was
previously
the lung
it was only reported as GCT, so metastatic workup was not done. That the patient didn't have the reports. But this time when it was biopsy proven, she underwent a proper formal staging workup, and she is known to have METs now. We don't have a comparative,
biopsy on lung.
Yes, sir, right and left both lung, 4 and 7.
I really don't know. I just had a case like this. We reviewed literature of, and actually we'll start with chemo or even Pembro. There is a data on pembrolizumab working in it. So I would start with it, but I will not be comfortable with whatever I do, even myself.
Any comments on that before we go to the definitive management?
No, not from my end.
Aman, would you like to counsel the patient? She's 34, ECOG1, recently diagnosed.
I don't have much experience about the ortho malignancies as such, but we need to work out it because now it is showing mets in the lungs, so definitely less likely to be a giant cell tumor. So I feel we need to look into more in pathology and look out. We don't know much about it.
Sani sir, your experience with this multiple mets in STS and bone tumors?
Well, I would like to know what is the disease-free interval between the last...
Sir, previously 1 year back was the last surgery, but that was reported to be, reported to be benign. This time, since 4 months, there is swelling.
At least
8 months around, there is a DFS.
At least an X-ray chest for general workup might have been done. We don't operate without adequate workup. So, although not for metastasis, just for giving general anesthesia. Even the X-ray chest is not available, or PET?
No, PET-CT is saying there is mets.
No, now it's PET-CT. I'm asking about 1 year back. I'm just trying to figure out whether they were there at the time or not.
We don't have the details, considering it was...
say that we are unaware about it.
So with that details we don't have, but considering it is a newly diagnosed...
Well, considering that 2 times it has been reported as benign, and now we find metastasis. And you say there were no imaging. So it's possible. Let us assume that they were there even last time. So it seems a disease which has been seen 2 times as benign and now appearing finally malignant. So that means it's indolent and it's slow growing, right? So there is a case to address the metastasis as well as the primary side, both together.
So your first option to the patient will be anterior chemotherapy and reassessment, sir?
No, not really. Maybe take out both of them. I don't know, as a surgeon, that's how I feel. Okay, if they are willing to give chemo, okay, that's fine. Let us know.
No, only please, there are 7 metastases. Is that right?
Yes, sir. So 7 and 4. 7 and 4. Right and left lung, 7.
Anyway, are they limited to one lobe or are they limited to...
No, sir. On both sides, I should have put the photos. Actually, this is the actual case we came across, and she had 23 mets overall, not just 7 and 4. Right side 19 and left side around 14 mets.
Well, then in that case, maybe a biopsy or at least take out maybe...
No, on PET, on PET scan, there were less actually, sir. But in our experience, we used to treat M1 disease as a curable disease, especially in STS and bone tumors, sir. So after anterior chemo, if the patient responds, we will reassess with PET-CT and thoracoscopy, as well as the primary should respond. And if they all are in favorable points, we will go for definitive surgery.
Well, 21 seems to be too many to address with surgical resection.
Sorry, sir?
21 mets seems to be too many to
Means 19 on one side and 14 on one side it was, sir.
So what I said, I actually meant it. I knew surgeon who has done this before me. I have seen this happening, so that was my experience. So he actually removed they scooped out these many meds from the lung. So. But I think if it's so many, it's better to start with chemo, because if we are not likely to remove all of them, then in any case we'll have to do chemo. But an NGS in this case could be of some help. And NGS, MSI, TMB, PDL1. Yes.
So to sum up, any comments upon this, or shall I put the actual case, what happened with this patient? It was one of the rarities, planning to publish as a case report. So patient was diagnosed with GCT, underwent cisplatin-based chemotherapy outside in Kerala. Her kidney succumbed to the chemotherapy. She had a sudden AKI and renal failure. We changed the chemotherapy regimen to adriamycin-based and then re-challenged with the second-line chemo, and she responded really well. But we did a staged procedure. We did the primary resection after almost 2 months of the chemo, seeing the disease was responding well to the chemo. That factors, ECOG1, patient willing, out of protocol treatment, all factors were taken, both tumor factors and host factors were taken into consideration. And after that, the second stage was after 6 weeks, we did the opposite thoracoscopy and resection. All were by mini thoracotomy. In the end, patient was kept on sorafenib and exentinib after that. She survived for almost 4.5 years. So with that time I am presenting this one. Why? Because this was told by my HOD to present, make sure that things he should also get to know. So there are multiple case reports with the numbers are 21, 18, 19, small case cohorts, but the disease-free survival or the overall survival has been shown by around 4 to 5 years if the NGS panel is in favor and the host factors are in favor.
So she had progression in the lung only when she died?
No, and best part is she did die of the malignancy. She had got tuberculosis. That was a biopsy-proven tuberculosis, and she succumbed to that after 4.5 years.
The HPR?
Sarcoma.
So non-metastatic was
Metastatic. Meds were removed and all were positive.
Being in osteoporosis management, I don't know.
That's what it was out of protocol.
We have only seen up to 4 to 8 lesions. I think we are treating it curatively because osteosarcoma in itself is a micrometastatic disease.
But it was giant cell rich, so it was little in more favor of a slow progressive disease. That's why. Anyways, I got a message just now to keep it short and close the session. Thank you everyone for chairing this, being the panelist for this session. I hope it was a little informative for our common audience as well.
Arun sir wants to add something, sir, please.
Sir will add SBRT to it.
Thank you, Dr. Nitik. We are a little late, so we proceed for the next session.
Thank you, Dr. Ritik sir, and our team of panelists. Each of you brought a very unique perspective to the table, enriching the dialogue and providing invaluable takeaways for all the attendees. Your passion for the subject matter was evident and truly inspiring. So, ladies and gentlemen, we will now delve into de-escalation of surgery in solid tumors by Dr. Chintamani, who is the chairman of surgical oncology in Sir Gangaram Hospital, New Delhi. And the session will be chaired by Dr. Smriti Gupta. I'm so sorry. The session will be chaired by Dr. Anurag Srivastav, Dr. Sanjay, Dr. Mukesh Maheshwari, and Dr. Vishal Saxena. Thank you.
लेक्चर आपका लोडेड है कंपल्सरी चिंतामणि का लेक्चर लोडेड है ऊपर, देख लीजिए.
So I can't control it.
सर पॉइंटर से लेफ्ट नेक्स्ट कर सकते हैं, पॉइंटर से करें.
This is not, I will just check maybe it's not working.
While they are setting up the projector, let me introduce Professor Chintamani, teacher of teachers, a very knowledgeable person with wide erudition and profound knowledge in the field of both theoretical surgery as well as skills. And he has been a great teacher and admirer of our surgical workshops conducted at AIMS, and he has always been a mentor and chairperson in so many lectures. So we are appreciative of your presence here. Thank you.
Thank you so much, sir. It's always a pleasure. And sorry I barged in. My talk was tomorrow, but I have to leave for some reason. So thank you very much for accommodating this talk. And I'm sorry, Dr. Sharma, for keeping you. I wouldn't do it generally, but there is a pressure to go back. Well, first of all, you heard beautiful talks since morning, and I don't know whether I'll be adding anything. If at all, I'll be probably sharing my ignorance on de-escalation. When you talk about de-escalation, it should not be escalation in disguise, because we've of late been observing that surgery is becoming more and more conservative, but the other therapies are becoming more and more aggressive. So you don't truly call it de-escalation, it could be escalation in disguise. So let's see if we can do justice to that. Well, these are my disclosures, some of the books from which and this is a recent one where Dr. Saini also features. This you must have seen. It's a beautiful write-up with a picture on the front of Time magazine. Breast cancer patient received neoadjuvant chemotherapy, tumor disappeared. Mostly we observe that the tumor disappears and so does the patient. Does it really work? Does it really work that way? There was a beautiful discussion on the colorectal cancer, and we know there's a group of patients, the rectal cancers, where you can leave it alone and observe. There is one very small segment of those. Although we got to be very cautious with what we are saying and what we are doing. You cannot be overtly thinking. Importantly, to be honest in science is very, very important. Not to be carried away by your own personal thoughts. Like somebody mentioned, I would not like to see the patient in my clinic at all, because I don't think patient deserves any confusion with medical therapy at that time. And there are patients where I would not fiddle with surgery. So it is possible to do it in breast cancer patient, and breast cancer is a very classical way to read about the rest of the oncology as it evolves. So that's why I'll take one example, otherwise it will never end. So complete response, older patients, DCIS. Some DCIS, do you know what? There were two beautiful studies where they observed that in the postmortem done on 8,000 men, 80% had prostatic cancer, but they never died of it. Similarly, women, 80% had DCIS and they didn't die of DCIS, breast cancer. So there are many people, most people in this hall are carrying some cancer, and tumor suppressed gene is not letting it happen. And in his own beautiful way, Dr. Rath mentioned cancer as a disease with a distinction. So you understand it differently if you look at it differently. So it may not need treatment all the time. And this is an important slide where you can see that from lumpectomy we could have moved on to balloon ablation. I am very happy if there is no surgery required for a patient. I am not worried about it at all, that I would not have anything to do. If none of us has anything to do in this world, patients and individuals, the world is happy. You know that. So it is not just because I need to be doing something and I am therefore going to be important that should take a call. Oncology as a principle should be adopted in all scenarios, whether it's surgery, radiation or chemotherapy. So organ preservation in cancer is how it all started, and we know how it all started. And I remember talking about this in an ASI lecture in 2002. And when we talked about organ preservation, I had to go through a lot of literature to find out what is it that I'm going to actually speak on. And I realized there is so much of potential in preserving organs, and we were still fighting at that point with the breast conservation or no conservation. So de-escalation as a concept started with the veterans trial, which happened in 70s and 80s, and we all know that. It was in the larynges, and it was found that in laryngeal cancer, locally advanced, 80% larynges that were sacrificed could have been conserved if we were using chemoradiation effectively. Today we don't subject them to that kind of a surgery. And voice is a very important function that everybody needs to communicate. So it was an important organ to preserve. So it was possible to preserve organ. And this led to some thoughts with concurrent chemoradiation. Can we treat? Radiation has been there for a very, very long time, and it really revolutionized management of breast cancer, other cancers, and in general cancer. But that was concomitant with some other adjuncts that we were using for making a difference. And that's the background, and there came a concept which is at the bottom. If you're not interested in reading the slide, there's nothing written there. Just focus on what is glowing or what has been highlighted. Conservative surgery sounds paradoxical. Surgeon, conservative, not likely to be. When we were trained, a tiger surgeon was somebody who could take out any tumor except when it was fixed to an operating table. But that era is gone. We don't need to do more than what we need to do. This is how it was defined, and I've taken this. This is from my old slide presentation. Every procedure that aims, it sounds very nice. Basically, anything that gets you a clearance from cancer, yet preserves all the organs. That is, you have best of both the worlds. Somewhere in the middle is where you live. Middle path is the way of life. That's what applies here too. This is another definition which appeared for the larynx, basically. The strategy of combining chemotherapy and irradiation in the treatment of advanced resectable disease to avoid radical and debilitating surgery. And with the evolution of chemotherapy, what has changed mostly? With the chemotherapy coming in, most surgeries have become relatively less aggressive. So we are using everyone to make it less aggressive, that is, relatively speaking, more conservative. Classical example of how we de-escalate. When we started, we were talking of 1.5 to 2 centimeter margin. It got down to 1 centimeter. Then it got down to 5 millimeter. I'm talking about breast only, just as an index case. And now no tumor on the ink. Barring DCIS, which started with 1 centimeter, remained at that 10 millimeter for a long time. Now it is down to 2 millimeter for obvious reasons, DCIS. Isn't that funny? DCIS is not even an invasive cancer. We do less. But for an invasive cancer, we do more for DCIS, we do less for invasive cancer. So this is gradually how you read science as it evolves. With more understanding of the biology, as somebody mentioned, biology is the king. Everything else is, whether it's a queen or a prince, but king is biology. 2 patients, 2 cancers, same stage, same therapy, same town, same doctors, do differently, and we know it. Breast cancer basically is a very useful model to read, and that's what I'm going to spend a lot of time on. It's a great success story. It's classical role model where we found that you can actually evolve from being extra-radical, the Hallstadian, to the Fisherian concept. It laid foundation for clinical trials. NSABP started with Bernard Fisher. It actually got us together. The concept of multimodality treatment came in. Otherwise, we lived in different buildings, surgeons somewhere else, radiation oncologist somewhere else, chemotherapists in some corner. So they are all together, and we are all adding up, and organ preservation became a feasible option in most cancers after we observed in larynx and then breast. Cross collaboration and integration of all other fields came in. Today you heard beautiful talk by Dr. Jaya Shukla on what can you do with the nuclear medicine, which used to be, when we were growing up, called unclear medicine. We didn't know what it does. But today we know you can actually make a big difference. Overall patient-centric approach came big time. Excellent role model for all the other solid tumors. That's what I am discussing. So these are the fallouts. It can therefore be applied to other cancers. That's one thing we learned. But what do you do when there is massive nodal metastasis, as the case discussion pursued? You shouldn't try to wish too much away. In the process, we will just observe these notes. We have observed that you observed, and they become non-resectable. Accurate assessment of response, if you're putting on any therapy, is very important, and patient's follow-up becomes important. Patient's actual real follow-up becomes important. That is with imaging of good quality. You need to know whether your response is accurate, and you should not define quality of life for a patient. Yesterday, I had a physics lecturer from Delhi University, and she was asking for mastectomy for a T1N0 M0 lesion. I spent the whole day convincing her that the outcome of breast conservation is superior to mastectomy even in terms of survival. For various reasons. We know that recent papers say it's not just equivalent, it is superior. She didn't listen to me. But I don't need to define for her quotient of happiness. I only had to tell her that we need radiation after all conservation. She said, if you need radiation, there has to be a doubt in your mind. I said, there's no doubt because there is breast, there can be another cancer. If there can be another cancer, why should I have breast? I'm 67-year-old. So there you are, so don't define it. This is way back in 2003, sir, and I want to share this case specially. This was an opportunistic screening in a corporate setup. This lady got a screening done. She had a very, very tiny tumor, as you can see there, and she was hell-bent upon breast conservation. And I was speaking the next day against the motion at a meeting at AIIMS against breast conservation surgery. And I was to convince this lady that it's not going to work out. We are not sure about, whether the recurrence rates are manageable. We knew at that time the local recurrence rates were higher to the tune of 5 to 6% compared to mastectomy. Today we know they are not. Considering the kind of therapy that is advanced, the radiation, this is way back. But she insisted, and I had no choice but to do surgery. Through the same incision, we could do the lumpectomy plus level 1, level 2, level 3. This picture is level 3. I think this is the pointer. So this is level 3 here, and you can see a good result. But when I look back at this picture, there's a depression in the upper outer quadrant because I left the seroma there, which used to be the protocol those days. Leave the seroma there, the contour would stay. But what would happen subsequently with radiation, seroma would disappear and there would be a little hole where the scar would go and get stuck and the nipple may get deviated. I would not do this today. She was very happy, still living, doing well. She's done well. She could have done with, this gives you a feedback that it's possible to do less when you think more. It's possible to do less. So we thought of oncoplastic breast surgery later on. So what do you fill it with? If you don't fill it with seroma, we need to either do volume displacement or volume replacement. Both these together are called oncoplastic breast surgery. You can split it into onco and plastic, where cancer surgery and plastic surgery are married and then they live together forever. So our surgeon gets further trained into doing oncoplastic breast surgery to give not only cure but also cosmesis, because these patients live long enough to be deserving to be living well. Now that is the round block mastopexy. For a similar lesion, that's why I wanted to show. You go through in the mastectomy plane, that's a specimen being removed, oriented, short superior, long lateral. We put the clips in the tumor bed for our very dear friends, radiation oncologists, to give the boost locally, to give radiation adequately. Their radiation has also become more and more conservative. They have de-escalated because their skills are better, their machines are better. We saw a machine today, and this center has some brilliant radiation facility, so you can narrow it down to what you want. I'm not talking about APBI, and there's more than just APBI today. Intraoperative radiation also come big time, and you can get the kind of results that you're looking for. And patients not only are cured of cancer, but they live with a normal, this is hardly a week later, a little bit of disparity with gradual, with the passage of time, this will disappear. This can be applied to many situations. We were taking a margin of 1 centimeter with the gross field so that we get no tumor on the ink on microscopy, because you can't see what the microscope can see. And to make it even narrower, we would use ultrasound on the table to mark our exact centimeter so that we are very, very close. And you can see that this works extremely well with ultrasound. Similarly, the central quadrant tumors, whenever you had to remove the nipple areola complex, we felt that this deserves mastectomy. No longer mastectomy, we can do oncoplasty with volume displacement using a rotation advancement dermoglandular flap, which is Grisotti, central quadrant marking. This is the new areola that will go up, and we'll create with tattooing a perfect nipple again. Rotated and advanced, and you can get an absolutely perfect result. If you get a defect somewhere, in any part of the breast, the tumor can be removed comfortably because oncoplasty allows you to take wider margins. You can use a light cap, or you can see a mark here. This is a very important take home. All inferior quadrant lesions in the breast should be taken out with a radial incision. What it does, if you take a horizontal, when parallel incision is, it will produce that bird beak deformity. Plus the other tragedy that happens is, lumpectomy was done to make a diagnosis and no orientation was done to the pathologist. The pathologist reported as one margin positive and we didn't know which margin positive. Patient came down because she was offered mastectomy now, so she came down for conservation. We had to resect it. We told her that this is a possibility, that we may need more than one particular type of procedure, and we managed it by round block mastopexy and using a LICAP, ICAP flap. You can see the flap, and you can achieve by filling from below, the flap can actually get the kind of result you're looking for. Friends, it's not our abilities that show what we truly are, it's our choices. And that's what has changed. If you really know what you can do, you can tell the patient what you can do. If you don't know what you can do, you'll tell the patient mastectomy. If you can do conservation, mastectomy shouldn't be offered. I'm not challenging mastectomy. There are places where you cannot escape it, but where possible, it should be avoided. Now, this is how the strategy is evolved. We have all heard about Halstead's view, Fisher's view. Since there are some students here, this slide is included. Although it's a very wise audience, I don't think I need to waste my time on that. But Halstead believed, and his belief lasted for 100 years. So don't take him for a joke. We don't live that long. In our lifetime alone, so many things have changed. Halstead's view came in when there was no such treatment for breast cancer. He was of the opinion, for all cancers, that there is an echelon method. It traverses from one to the next point, to the next, to the next. So to get a clearance or to get a cure, you need to take out all the echelons en bloc, which meant hugely, hugely radical. And mind you, for the first time when he presented his data of 18 cases, he showed a 3-year survival rate of 45%, which was remarkable at that time because most used to die. The opposite of a correct statement is a false statement. The opposite of a profound truth will be another profound truth. Fisher came with a view in 70s that at the onset, breast cancer is a systemic disease. So don't have to be aggressive locally. You need to take care of the systemic disease. Being extra radical locally doesn't really help. He had a view, but that did not prove Halstead wrong because you still do sentinel node biopsy, believing that it's level 1 which gets involved first. So we take the middle path of Buddha in most situations, including here. This is Halstead, and this was a shift of paradigm for the first time. Before that, it was all over the place. People were treating breast cancer in a variety of ways before he presented, and that's another important thing. To be presenting your data, to be documenting what you say. It's not about, I like to do it this way. It looked like a theater, and you can see that everything was almost removed. Both pectorals, supraclavicular, infraclavicular fossa, all were removed. And from radical, we evolved into becoming radically conservative. Kattar Beiman, Kattar Imandar. You know, they're using Kattar effectively. So radically conservative would mean you are here conservative, which doesn't mean you do inadequate surgery. And this is how it all evolved. I'm giving one example, there's no point covering all the cancers. From B4, B6 trials, which made lumpectomy followed by radiation as good as radical mastectomy or simple mastectomy without radiation. You know this 25-year study when, this is the basis of so many other trials that happened later on in breast, so I won't go there. And B17, which brought in the DCIS margins and all these other studies, and bottom line, Z11, Ameros, sound trial, etc. We are still contemplating, can you spare axilla or not? We won't go into that gray zone. And finally, the oncoplastic leap, it is changing everything. We get wide margins, we can conserve most breasts. But no amount of belief can make something a fact. You believe it, that doesn't make it a fact. So, in God we trust, all others must have data, and therefore, except God, everybody has to produce evidence. And there is evidence to show, this is what he had to say, great man who brought in a concept, surgeon himself, but he believed in science. And science is not about being rigid or radical. I'll share with you one very old anecdote. I was moderating a debate, and the debate was between endoscopy versus surgical CBD exploration for CBD stones. And in that whole argument, it got a little heated. And all surgeons talking, I was moderating the debate as you would moderate. And then from the crowd, when we were looking for the voting, a lot of people got up and said, CBD belongs to the surgeons, it should not be handed over to the endoscopists. And the chaos was on. I said, CBD, for God's sake, belongs to the patient. So we should not be fighting over what you can do, what I can do. What is useful for the patient should be our bottom line. NSABP, I won't take you there. B32 brought in the concept of sentinel node biopsy. Sentinel node biopsy is a beautiful concept which has got further narrowed down. You pick up the first echelon node. If it is negative, axilla is spared. If it is positive, we do the axillary dissection. But now we have Z11 where even if it is positive, 2 to 3 nodes, we don't replicate it in Indian scenario, you can spare the axilla in select cases, but we don't practice it in this part of the world. But it made our job easier. Well, coming to the bottom line, therefore, equivalence or superior, stage 1 and 2, less is more. Equivalence was proven by B4, now BCS is superior to mastectomy. Now it's been proven beyond doubt, and mastectomy doesn't improve survival. I wanted this take home for the residents especially, and mind you, this is based on enough evidence, and then there are hypotheses and theories. Why should mastectomy be worse than conservation in terms of outcome? Mastectomy or any extra surgery leads to immune response, leads to more metastasis, more cytokines, more interleukins. So aggression is not always good. And we found that post-neoadjuvant chemotherapy, sentinel node biopsy is reliable. Now, of course, there are the Sentinel trial and many other trials have proven. Beyond this, we have done the targeted axillary dissection recently, and we found out that with clipping of the node, and if you find the same node as blue node and the hot node, you can actually do selected axillary dissection, like you have functional neck dissection. But remember, the devil is in the details. I do some bit of wildlife photography. These you can see are the tires of the Jeep, and we are looking for some things. Look here. These are the pug marks of the tiger. So you can miss. The devil is in the details. So don't take a Western trial and ape it and replicate it in this part of the world. Unless you have your own evidence, you will not find Indian solutions to Indian problems. Beautifully, very simplistically brought out by Dr. Rath. Certain sentences, one-liners are words and pearls of wisdom. They stick and you realize, oh well, there you are, 80-20. Beautiful way to imagine and understand. But unless you know your problem, you can't find your solutions. You will keep quoting Z11 and you'll keep treating. You'll say MROs showed 10 years later the lymphedema rates were higher with surgery than radiation. It's not correct. We don't observe it. Observe in your patients, show your data and compare. We don't see such a high incidence of lymphedema following axillary dissection. I'm not saying it's negligible, but it's not that high.
And what is covered may be precious. This is Bandipur Tiger Reserve. What you see is a termite mound, looks beautiful, but what is inside is a sandalwood tree. You wouldn't miss that. It's like missing an elephant for a fly. So don't just miss those minor points there. In Z11, all patients received tangential breast radiation, which covers up level 1 and 2 automatically. So you are providing in one arm, not just you not dissecting, you're also giving radiation. You are addressing the axilla, and radiation is also a cutting arm. So be careful. So is last few slides, Indian breast cancer and the paradigm. Are we the same cancer like the ones in the West? There are many papers on it, and you wise people who would think differently. Unlike in the West, where there is one peak as you go up 60 and beyond that, we have 2 peaks of breast cancer, aptly proven. This was way back in 2005, and you have 2 peaks. So the first one, we were always wondering, they had more BRCA1, BRCA2 sequence alterations. ICMR was doing this study, I was part of it, and later on, they had more the gene polymorphism that you could observe with CYP17. And they are high. Then we dug out this archived data, specimens, and we found that they are what we call today as triple negative breast cancer. So our cancer is different, so we need to plan accordingly. We cannot be doing what the Westerns do. I'm now looking at the flip side. I will need 5 minutes, please. BCT, is it possible in India? Need to qualify. Sentinel node biopsy, can it be the standard of care? Is our cancer unique? It is unique in the way it presents. Can we do something which is India-centric? Fluorescent studies by Dr. Anurag Srivastav, I replicated in many patients. I started using for reverse X-ray mapping, useful. Or the Edinburgh pattern we use for blue node sampling. So is still an aggressive approach justified in an aggressive cancer? The answer is yes, but not for an indolent one. Welcome to reality. There is no difference in theory. In theory, there is no difference between theory and practice, but in practice there is. Most of our cancers are like this. So don't try to replicate, and please allow me those 5 minutes so that I can actually wind up what I'm trying to say. This would lose the breast. This would lose the mandible. Don't waste time thinking about it. You have a scenario where you don't have a choice, but it's anterior segment disease. We can get a clearance if you're getting an R0, RND on the right side, MND on the left. It's a very old case. Maybe this kind of a patients still present to us. Or a thyroid operated, you can see the scar, patient presenting with a stoma, tracheostomy, because patient developed stridor and patient has already been operated. Suboptimal work for cancer. It can go bad. Not all thyroid cancers are good. When they report on thyroid cancer, is the first one. The moment recurrence happens, it's a different disease in most cancers. And you can see it's a larynx involved. We had to do laryngectomy, resect it out, because there is no other treatment available. You need to be aggressive in this. There is no de-escalation here. You need to be balanced in your mind. When you're doing Whipples, and if you do not take this sheath margin and send it for the frozen, prove it to be negative, it's an inadequate job. Otherwise, it looks nice. You need to look for the superior mesenteric and uncinate margins. Radical chole, take out gallbladder only when you've got the clearance adequately. Lymph node clearance has to be optimal. It's a surgical disease. There is no de-escalation for cancer gallbladder. You can't play around. It's a total waste of time. They need surgery, radical one, at the right time. With that, ladies and gentlemen, I would like to basically mention a few scenarios. This is, of course, medullary, where you don't have a choice. You go bilaterally, you go aggressive. This is central plus lateral neck dissection. You can see the accessory there. And what they were referring to was 2A and 2B. For those who want to understand, it is not 2 miles away. They're just there. And this, being fussy about it, is in a Western scenario where there's no node, it's a clear-cut dissection. In our patient, you'll generally find it on both sides. Then you don't have a 2A, 2B confusion. That confusion happens in very, very select scenarios. Bilateral neck dissection with total thyroidectomy and central neck dissection being done. And you have to achieve clearance like this. We still need it. It is safer to, neck recurrence is disaster. X-ray recurrence is a disaster. When you get it, you know that I should have cleared it that time. Leave your patient to adjunct therapy after a good R0. No disease should be left. Oncological principles don't change. complete dissection on the right side. You can see the parathyroid there, central fat, and of course the rectal laryngeal nerve. And last case, this is a primary squamous cell carcinoma of parotid. We reported primary squamous cell carcinoma of thyroid also, which the previous one you said, we reported 2 cases, there are 82 cases, so 80 have been reported before. Patient has been operated with a fungation there, has come with a facial palsy. Patient has come with tarsorrhaphy. We didn't have a choice but to go radical in this case. Well, finally, this is where I wanted to bring in Dr. Anurag's fluorescent. We wanted to find out if we can do less in axillary dissection. So we looked at reverse. Basic idea is to prevent arm lymphatics being removed. So we did fluorescent into the arm and blue dye into the breast, and we just removed the blue nodes and then checked with the blue light, which he had gifted me. I think we found out it's 150 rupees. So thank you for that. First of all, introducing me to that. And there's a torch that has come, and we can find out that there the lymphatics stay mostly above the axillary vein and the superior most intercostal brachial nerve. So in your technique, you can be de-escalating. In head and neck, already discussed, mandible was earlier removed routinely because we believe the lymphatics go through the mandible, but they don't anymore. And I'll request my friends, colleagues here to go through my latest atlas on neck dissection, which is the 3rd edition, where we have described a totally different incision, unlike the 2005 mini atlas of mine on neck dissection, where we used the old Schobinger. We have changed it, we have de-escalated. Larynx, I've already mentioned. GI has already been discussed. I won't waste time there. Effort is to have sphincter preservation. And soft tissue sarcomas, the effort is to preserve limb. But that doesn't mean upfront radiation is very useful in some scenarios because it stands out, especially in retroperitoneal sarcoma sometimes. But by and large, another surgical disease where you must get clearance and a wide clearance before we close. Similarly in bladder and prostate. To conclude, ladies and gentlemen, pardon me for taking those 3 minutes extra. This is General Douglas MacArthur, who was in the Second World War leading the Eastern Front. When his second in command came and asked him, what is the next instruction, sir? We have been bombed on this side. So he said, we will move to Philippines. So they asked him, are we retreating, General? He said, no, we are advancing in another direction. So de-escalation is not retrieval. Nobody should feel that if I'm doing less, I'm losing it at any point. We are advancing in another direction. Thank you very much, ladies and gentlemen. Thank you, sir.
Thank you. I would like Professor Rath to say a few words.
Fantastic lecture. As a excellent teacher. Thank you very much.
Thank you, Dr.
Thank you, sir. Thank you, sir.
Thank you, Dr. Chintamani sir, for your presentation. We are grateful to have had the opportunity to learn from you, and we would like Dr. Anurag Srivastav sir to please felicitate Dr. Chintamani sir.
Dr. Sharma, I'm sorry to have delayed you. It was your talk.
So, as we know, it's Dr. D.N. Sharma next, who is a professor at AIIMS New Delhi and NCR Jhajjar. He will be having a talk on precision in action, optimizing cancer treatment with brachytherapy. And this session will be chaired by Dr. Smriti Gupta, Dr. Kishore sir, Dr. Udit Chauhan, and Dr. Brijesh Goswami.
I'll be brief. I'll be very brief because it's the dinner time. Respected chairpersons, my dear teacher, Dr. G.K. Rath, ladies and gentlemen, very good evening, and thank you, Subharti, for inviting me and giving me this opportunity to share my views. Title of my talk is a bit long, Precision Action, Optimized Cancer Treatment with Brachytherapy. Although precision is a word which is vital across all the medical fields, but more so for radiation treatment, we define precision RT as the precise simulation, planning and delivery of the conformed radiation to the target volume to improve the local control and the therapeutic ratio. There are various forms of the precision RT, namely the 3DC RT, IMRT, SBRT, proton, and there's a long list, and brachytherapy as well. But remember, the brachy doesn't mean that it's at the bottom. It is most conformal treatment across all the medical, all the radiation armamentarium. It's a proven science. It's not that it's a new treatment. It's being practiced for last more than a century. And it's a very accurate, very precise sort of a treatment as far as radiation is concerned. It is minimally invasive, dependent on the expertise, and it has a very high therapeutic ratio. That means good local control and minimal toxicity. The treatment course is very short, and it's a naturally occurring hypofractionation. It is very resource friendly because you need a small machine which is of barely few crores, and therefore it is very cost effective, and it suits the Indian economy. The modern brachytherapy is based on the stepping source dosimetry called SST, and due to this, we can change the dwell position, we can change the dwell times, and therefore you can have any shape. If you can just have a look here, you can have any shape of the dosimetry and you can treat any shape of the tumor. So modern brachy is very precise, very conformal. And if you compare the various treatment modalities in the radiation treatment, this is graph shows the various adaptose characteristics. If you see the, I think this is not okay. If you see the proton beam curve at the and you can say right hand side, there is a very sharp decline in the dose, and therefore the exit dose is very, very less, almost like negligible. So it is very conformal. If you see the brachytherapy on the left hand side, it is equally declining sharp. So therefore the dosimetry of the brachytherapy in proton is not very different. You are as conformal as protons if you do brachytherapy. And just to show you one of the pictures, this is our study where we have tried to compare the brachy with the IMRT, and this is the patient who had undergone the template in our department. And what we did that we, on the same set of images, we tried to plan the IMRT by throwing 7 to 9 beams. And when we compared the dosimetry was far better with the brachytherapy as compared to the IMRT. I will not go in details, but this is already published in brachytherapy in 2013. So if you want to see the details, you can just go through this study. The reason why the brachy is so conformal because the dose deposition is dense in the target area, unlike the brachy, unlike the IMRT where the dose spill is there in the entry and exit beam, as you can see in the bottom picture. Although any malignancy can be treated by brachytherapy except the leukemias, but these are the common indications of the brachytherapy. Gynecological cancers, breast cancer, prostate cancer, head and cancer, sarcomas, skin and esophageal tumor. There's a long list. You can treat virtually any tumor by incorporating brachy either as a boost or as a monotherapy. We'll first take the gynecological cancers because they are very, very common in our country. Starting with the cervix, this is how you treat the cervix. You first give the EBRT to the pelvis, covering the primary tumor and the parametria and the nodes, and then you give brachytherapy for covering the primary tumor and the part of the parametria. So this is how these are two optimally combined in order to get the best results in terms of the local control and the survival. There are various protocols being followed in our country. I just picked the 3 protocols being practiced in the leading institutes in this country. We practice 50.4 in 28 fractions over 5.5 weeks by EBRT, and then followed by 7 times 3 weekly schedule. And the Tata Memorial and the PGI, they perform 45 gray or 46 gray EBRT to the pelvis, and then followed by 7 gray times 2, 7 gray 4 to the in the Tata, and 9 gray times 2 in the PGI. So more or less the total dose remains around 80 to 85 gray, although ABS recommends 90 gray, but I think it's not easily practical in our setup to deliver 90 gray to HRCT or point A. So therefore, the message is that it should be, cumulative dose should be at least 80 gray, if not 85 gray, because that's how you can cure carcinoma cervix. And why breaking cervix? Because if you see the image at the bottom, the pelvis is tightly packed with many organs like rectum, bladder, small bowel, ureter, and there are so many organs. So they are tightly opposed against each other. So you need a conformed treatment in order to deliver that 85 to 90 gray. And without brachytherapy, you cannot achieve that dose in a region where there are so many organs which are in the close vicinity. Few people try to replace brachytherapy with the modern SBRT and IMRT, and they have miserably failed. If you see this graph, there was a decline in the practice of brachytherapy in the cervix from 2005 onwards, because that is the time when the IMRT was taking a surge. And if you see the other graph at the bottom, the patients who were treated by brachytherapy has a far better survival as compared to the patients who were treated by SBRT and IMRT. So therefore, if you try to replace brachytherapy with the SBRT or IMRT, you are going to fail as far as CS cervix is concerned. So these are the various, this is one applicator which is commonly followed, but there are many applicators in the market now. The idea is to get a pear-shaped isodose for boosting the primary tumor and the parametria and part of the uterine, part of the uterus. If patient is not fit for intracavitary brachytherapy, then you can perform interstitial brachytherapy, although nowadays we have hybrid applicators as well. But these are the various indications of interstitial brachy. Lesion size more than 4 centimeter, distorted anatomy, parametrial disease not being covered by the ICRT, vaginal involvement in patients who have been operated. So in these patients, you will have to perform interstitial brachytherapy either by a template or by some other means. These are various applicators which are used for practicing the interstitial brachytherapy. The first one is vein applicator, where you have the needles into the ring, and then you have the rotatum applicator, and then you have classical Meerut and the Nisarse template. The last one is the fourth generation template called the Venigi applicator, by which you can practice all sort of brachytherapy, including intracavitary, intravaginal, interstitial, and hybrid as well. So you can, with this, although this is new in the market, but with this you can perform all sort of brachytherapy, and the best part is this is MR compatible. So you can do the imaging with this, and you can do the 3D treatment by this treatment. There's one patient who have been treated, which has been treated by us at our center. If you see 5-6 needles around the cervix, and since the patient was having a large tumor, so it was not being covered by the typical classical intracavitary, so we performed that vein applicator covering the interstitial brachy, covering the entire cervix, cervical tumor. But remember, with this kind of vein applicator, you are not able to cover the parametria. So if you want to cover the parametria, then you have to do the classical Meerut template brachytherapy. This is the patient which has been treated by Meerut brachytherapy. Nowadays, with the imaging, it has become very easy. We do the ultrasound for guiding the implant, and then if you see, the bladder is away from the template needles, and then the rectum is also away, and then you do the dosimetry, and if you can see, the bladder is spayed and the rectum is also spayed, and so the modern brachy is very safe as far as interstitial brachy is concerned. This is our publication published way back in 2010 on Meerut brachytherapy. The few more examples for interstitial brachy in the gynecological cancers. This is a patient of periurethral cancer where the surgery was not possible, because if you take margins, then you are going to sacrifice the part of the urethra. And since in females, urethra is very small, just 3 to 4 centimeter. So the patient was referred to us for brachytherapy, and as you can see, with the ultrasound, transvaginal ultrasound guidance, we did the implant to avoid the urethra. And as you can see, we implanted with multiple catheters, plastic catheters, and then this is the end of the implant, completion of the implant. 9 catheters were inserted, and then with the imaging, as you can see, the top white line is still the urethra. So that was partly spayed, despite the tumor being very close to the urethra. Another patient was an elderly 85 years old lady with carcinoma vulva, not fit for surgery. So therefore we did a brachy implant. It was on the lateralized aspect of the vulva, and we give a dose of around 40 to 50 gray if we are treating only by brachytherapy. For the boost, we are giving 18 to 20 gray. So it is in C vulva also brachy is very, very useful. Another patient who had a radical vulvectomy a few years back and then recurred, and when patient came to us, the further surgery was not possible, so we chose to treat this patient by intensive brachytherapy, and it is very simple. As you can see, just demarcate the area you want to implant by drawing the 4 lines, and then divide by 1 to 1.5 centimeter, and you can easily decide the number of catheters to be inserted. This was treated by 2 plane because the thickness was there. Another patient who had a posterior vaginal growth which was very close to rectum, and if you perform surgery you will need a colostomy, and therefore it is a huge compromise the quality of life for such a small tumor. And if you do IMRT, then IMRT in this kind of a location is very risky because the rectum is very prone for errors. Even with the flatus, the movement can be there, or the fecal matter. So, and you need a margin for treating with IMRT. But with brachytherapy, you don't need a margin. So what we decided, to implant this patient with the help of the transrectal ultrasound guided brachy implant. If you could see there, the top, at the bottom, there are 3 white dots. These are the needles on the ultrasound imaging. You can see now this is the tumor which was visible. You can see the ultrasound tumor also on the ultrasound. So this was the target area and 3 needles, and you see the dosimetry nicely covered. The anterior wall of the vagina is far away. Rectum is closed, but the tumor was also very close. So, but we were able to still spare the major part of the rectum. And if you see the slice of the target area, because the tumor was located posteriorly, I'm sure you cannot treat this patient by IMRT because such a tumor which is very closely abutting to the rectum and to the vaginal wall. Now let's come to the breast. In breast, we can perform brachy for boost and for APBI, that means treating only with the brachy and not giving external treatment. And even rarely for a chest wall recurrence, especially after the post-RT, you can treat by the mold brachytherapy. These are the patients suitable for the APBI. I will not go in details, but in nutshell, tumor size less than 3 centimeter, age more than 40 or 45 years, and nodes negative, but sometimes even with N1 we can take this patient if the other factors are positive. And the patient having margin positive are not to be taken for APBI. And there are 2 techniques for performing this brachytherapy for breast. One is the intraoperative or the perioperative technique where we insert the catheter during the surgery. And in my opinion, this is the best way to do the implant because the surgeon is there with you in the operation theater, and he will guide you that where was the location of the tumor, how thick was the tumor, and patient is early under anesthesia. You can perform the implant very easily. Otherwise, you need another sort of anesthesia if you do post-operatively. And the brachy treatment or the radiation treatment is complete less than a week, and even before the stitches are out. So we are completing the surgery and the radiation together within a week, and therefore it saves your time, it saves your slots on the machines, and is highly conformal. So this is some of the pictures that is very conformal. The other way of doing brachy is that once you have all the pathology details once the patient has been operated, because only downside of the first technique is that you do not know the pathology details. The node might be positive, the margins might be positive. So therefore, but if you are in a setup like high volume centers, you know the margin positivity with your surgeons, and in our setup there have been only 1 margin positive in my entire career. So we know our surgeons are very efficient, and therefore the margins are not positive, they are rarely positive, so therefore one can perform the brachy even with this kind of technique. The other technique is that if you are starting and you want to know the entire pathology details so as to assign the patient whether to go for boost or for the APBI, then it is to be done after like 3 to 4 weeks from the surgery, and this is how we do. We do a CT scan a day prior to the procedure, and where you can see all the clips very precisely. Our surgeons have the habit of putting the clips for every patient, whether patient requires radiation or not. And if you can see here, all these 4 clips, the cranial, caudal, and then the 2 little clips, and based on these clips, you mark the skin 1 centimeter all around, just something like. I'll show you sometime later, but based on these clips, you can demarcate the area to be implanted. just 1 centimeter all around. So showing the first technique that how do we do intraoperative or perioperative brachytherapy during surgery when the lumpectomy has been done, and then you decide what area is to be implanted, and the first implant has to rest on the muscle. Make sure that it doesn't float in the cavity. It has to be resting on the muscle so that you can cover the base of the tumor very well. The second plane has to be around 1 to 1.5 centimeters from the deeper plane, and I simply put a finger which guides me to do the second plane, So usually for boost you'll require 2 planes, but for APBI where the brachy is the only treatment, you'll require 2 to 3 planes. And this is how we close and button the catheters. And previously we used to leave the cavity and seroma, but nowadays we don't leave the cavity. But if you see, the cavity is very nicely covered by the catheters all around. And if you see the dosimetry, it is the dose which is covering the tumor very nicely. The skin is not getting any dose, the underlying lung, and especially for left side tumors where you have an underlying heart, so even heart is not getting any significant dose. So with this kind of technique, you are highly conformal. You are covering the cavity very nicely, very precisely, and then you are not giving any dose to the skin and to the underlying heart and the lung. Results have been already published. I'll not go details. Tumori, almost 100 patients were treated by this technique, and not even a single had a recurrence. This is the second technique of the breast brachy, where you do it after like 4 weeks from the surgery, and you do an image, and as you can see the clips, and then all around you mark the area onto the skin, and you will see something like this, that with the ink you can place the marks on the skin, and you have to confine your implant within these 4 lines, and then you are mostly going to be accurate and precise. Another patient, just with the clips, you can see how the catheters are put. And at the end of the treatment, sometimes you don't even realize that the treatment has been done. Normally, when you treat the EBRT, you will have some blackening on the skin or some sort of a discoloration on the skin, and you can immediately make out the patient has received radiation. Our surgeons sometimes get confused that patient has received radiation because there's hardly any marks on the skin. And I zoomed this picture for you because you can see the marks of the brachytherapy catheters on the skin. And I show these marks to our surgeons that patient has received the radiation. So, but these disappear within a span of like 3 to 4 months, and then patient has a utmost quality of the life and the cosmesis. Coming to another common cancer in India, head and neck cancers. Head and neck is one area where the multiple functions are located, like speech, smell, taste, sight, and swallowing. All these are very vital functions and this is one region in the body that having so many functions. So, and all these organs are like so tightly placed against each other that you need a very conformity, because if the dose spills onto the another organ, it can affect the patient's the quality of life and the function of the organ. So you need to have a very conformal treatment, especially for head and neck region where the many organs are up against each other. So these are the various organ sites where you can perform brachytherapy, starting with the lip, floor, mouth, buccal mucosa, anti-tongue, gingiva, base of tongue, and even for nodes we have started doing even the node brachy as well. But the lesions which are closer to the bone and where the margins are where there is a risk of the vessel injury, these are the relative contraindications for the brachytherapy. Mainly if the tumor is small, then we treat by brachy alone, which we call it definitive brachytherapy or monotherapy. If the tumor is bigger, then we can use brachy as a boost and the EBRT for treating the larger area, including the nodes. Just one example, a patient, these are typical examples. In any OPD you will find these kind of patients, little bone of the tongue, having a tumor. Patient is a teacher by profession, so he didn't want to lose his tongue. And, okay, just 2 minutes, yeah. So this is how we implanted the patient. As you can see, the tumor has been covered all around by the catheters. And this is the same patient. And then this is how we complete the implant by putting the buttons at the skin surface. And then just to show you that how it is compared with surgery. In surgery, you lose the organ, unlike with brachytherapy, because many of the colleagues consider that radiation brachy is invasive radiation treatment, but they must remember that this surgery is far more invasive. And if you don't do brachy, then surgeons are going to operate this patient and remove even half of the tongue. Another patient, tumor at the angle of mouth, and so we decided to do a single plane implant because thickness was not very much. So we did a single plane implant, very simple, just 4 catheters in a single plane. And then at the 1 month, you can see some discoloration at the skin, which was diluted because we wanted a good dose at the skin. But the mouth opening is very good, because one side effect of surgery in these patients is that there can be microstomia. But if you see after brachytherapy, the mouth opening is very, very good in these patients. And I'm sure you know this celebrity. This patient, he also had a tumor at the angle of mouth, but he was operated and then he was given radiation. And you can see he is hardly able to open his mouth, and his microstomia, he is hardly able to speak. And just to compare, if you treat the angle of mouth carcinoma by brachy, the quality of life is very good, the mouth opening is very good. But if you treat by surgery and by operating, the patient will have a microstomia and the quality of life will be compromised by altered speech and even the swallowing and even the cosmesis. Base of tongue also you can perform brachytherapy, especially the recurrent base of tumors, although now the TORS has come, but still I find the brachy is very useful. Even up to the like valvular you can approach by brachytherapy. This is one publication where the IMRT and brachy has been combined. We usually compare IMRT and brachy just to fight, but I think we need to complement each other. We should do best of the EBRT and we should do best of the brachy so as to get the best results. Many people think that head and neck brachy is declining. To some extent it's true, but let us not forget that if you don't do brachy, your survival is going to compromise. This is one publication in brachy 2016 where you can see that one set of patients were treated by EBRT alone, the lower graph, and the other set of patients were treated by brachy alone or combined with EBRT. And you see even at 30 years, the survival advantage is there with brachytherapy. And if you see the p-value is highly significant. So if you treat these patients by brachy in some form, either boost or monotherapy, the survival is going to be definitely better. Even with forest plot analysis, you can see all patients, all subgroups like sex, race, at the sites, all these sites had a fairly better survival as compared to the EBRT alone. This small soft tissue sarcomas is very common tumor again in our country. If you operate, you have to naturally operate this patient, and after surgery, many of them will require adjuvant treatment. And adjuvant treatment, you can choose brachy if the tumor is completely resected. It is high-grade tumor, size less than 10 cm, and the tumor bed is evenly surfaced. And rest of the patient you can combine with EBRT. And I'll just be brief. This is how you do. It's a single plane implant. It's a very easy implant, and I tell my students that if you want to become brachytherapist, start with this soft tissue sarcoma, because it's a single plane implant. Just at the base of the tumor, you just put a single plane implant. Rare sites, these are some of the examples we have treated. A patient who had CA penis. Of course, no patient would like to be operated for this kind of lesion, and he was referred to us, and we did the brachy implant for this patient. If you see the lesion was sandwiched between the brachy buttons, and then the picture at the 6 month of the treatment, and you can hardly see whether this patient had a tumor on the glans. Another patient who had a boost because it was a larger tumor, so we did a boost by brachytherapy. This data is published also in brachytherapy, so if you want to see the details, you can go through. Lung also we are doing, especially the solitary lung mats. If you see, this patient has a pat avid lesion at the apex. And then this is how we put just a simple one needle, and you see how conformed. The best part is that if the patient breathes, in IMRT it can be a problem due to motion artifact, but with brachytherapy, even if it moves, it doesn't matter because the dosimeter moves with the breathing movements. Even with liver, we are doing, it's very simple treatment. You put just 2 or 3 needles in a tumor like this. We were treating even larger tumors which were not operable and which were not amenable for any kind of other treatments. So we put, this was a 7 centimeter liver metastasis, we treated by putting 4 needles into the lesion. Node brachytherapy, I just started. People don't operate these patients because these are adherent to the underlying vessels and they are not operable. And these patients die within few months because there is no effective treatment for them. And what I did was I did a Doppler guided implant, because with Doppler you can see the vessels, and the only risk is that you have to avoid vessels here. And this is how the Doppler was done. If you can see, the colored part is the vessel, and above that is the node or the tumor. So once you see this vessel, it is very easy to avoid the injury to the vessels. And then you do angiogram, CT angiogram, and you can clearly see the vessels. You can see the tumor, you can see the catheters, you can see the blue is the common carotid, and above that is the two external internal carotids. So once you do this kind of implant, you can very easily shape your dosimetry up to the Just to conclude, brachy is an excellent therapeutic modality. It's very precise, very accurate, which is cost effective, very user friendly, resource friendly. It requires simple skills. People say it's a complicated or a skill treatment, but I always say that it requires very simple skills. Let us not compete with IMRT or VMAT. We should complement the brachy and the IMRT together, because they both are conformal treatments. And we should exploit the benefit of all the modalities of treatment along with brachytherapy. Thank you very much.
Brachytherapy on the front.
Thank you, sir.
On an electron also. So what is comment on this type?
I don't understand why people not get procuring brachytherapy. It's a simple machine. It's a portable machine. You can take it even to the operation theater also. It doesn't require a very large setup also. And as I showed you, you can treat almost every tumor, and it's as precise, as accurate with other forms of treatment. I'm not trying to replace LINAC with brachytherapy, but it is a very good way to treat many of tumors. It can save your load. It can save your money. It can create your slots on EBRT machines. A smart person will do that, because if you take these patients, if you take 5 patients of breast on brachy, you have extra 5 slots on LINAC, which will generate money for you. So a smart people will definitely procure brachytherapy. And I think if you see NMC rules, you cannot have a teaching center without the brachytherapy. Medical Council of India is very clear about that. The MD cannot be recognized until you have the brachytherapy there. So I don't understand. You can name. You can tell me which centers I can try and convince them.
Thank you.
Sir, we miss you very much, sir. Sir was so supportive that we had very nice surgical support from sir, and he used to give us such nice ideas, regarding the breast brachy and all that, So it's maybe because since our surgical support was very good, we could do all these kind of brachytherapy. And I always tell that without the surgical support, brachy cannot grow. So thank you very much, sir. Sir.
Coming and giving this nice talk.
Sir.
And we remember those days when you used to come and scrub with us.
Yes, sir.
And then we'd remove sarcoma or remove the breast.
Yes, sir. Yes, sir.
And then you would spend hours calculating it precisely and teach his residents how to put the tubings, the distance.
Thank you, sir. I always believe that the brachytherapy is like half surgeon, I spend 4 days a week in the OT, so it's not like surgical attitude. Yes, full sir. Thank you, sir. Thank you very much, sir.
Thank you, Doctor.
Just put the tubings. It is killing this. It is cytotoxic, right?
Yes, sir.
So without excising the surgery,
sir, I remember, sir.
just place the tubings and let the radiation, the gamma rays or the alpha particles kill the tumor cells without the knife, without removing the
principle of surgery and anoxic. Principle of radiotherapy. But
सर ऑस्टियस डिजीज में तो आप करते हैं मेंटल
Sir, thank you, sir.
Dr. D.N. Sharma for your invaluable contribution to the synopsium. I would like Dr. Kishore sir to present a facilitation. Lastly, Dr. Shyam Visht from Medanta, Gurgaon will shed light on elucidating the benefit of stereotactic body radiation in liver cancers. This session will be chaired by Dr. Anurag Srivastav, Dr. Kishore Singh, Dr. Amit Jain, Dr. Deepti Sharma.
So I'd like to invite Dr. Shyam Visht. He's working as Associate Director in Radiation Oncology at Medanta, Gurgaon, and we'll be speaking on the role of SBRT in HCCs.
Good evening. Thank you, organizers, for the kind invitation. So I'm standing between you and lunch, so I will try to just hurry up and try to simplify. The slides, please. Yeah. So the mandate given me to is the role of SBRT in liver cancers. So before going on to the liver cancers, I will be touching on few basics like LIRADS. LIRADS is basically applicable in case of cirrhosis, hepatitis infection, where there is a risk of having the HCC and a history of HCC. So in all the three areas, we should apply LIRADS. So when we see a LIRADS, the most characteristic features on the CT scan or on the MRI is arterial phase hyperenhancement plus few other features like you can see a very beautiful So the features are the enhancing capsule, the central part or non-capsular washout, rapid washout after the enhancement, and a threshold growth. That means a doubling it around within 6 months or more than 6 months. So it gives a report like this, LIRADS 4 or 5. If it is 5, there is a very high possibility of having 90-95% possibility of having carcinomas, and LIRADS 4 around 60 to 70% probability. Normally in LIRADS 5, we directly go for treatment. In LIRADS 4, many people they follow, wait for at least around 6 months and repeat. Sometimes some people follow at 3 months to see the threshold growth. One staging which is very important in case of liver cancers is BCLC, Barcelona Clinic Liver Cancer Staging, which divides the liver cancers in stage, very early stage 0, that means less than 2 centimeters, early stage, stage A, which is between less than 3 lesions, and maximum less than 3 centimeters. The intermediate is multinodular B. Advanced stage C is when there is a PVDT or an N1 or M1 and terminal stage. What are the treatment options in case of liver carcinomas? First is resection. When the liver is good, there is a single lesion less than 3 centimeters, then you can go, and there is no features of portal hypertension, liver, then you go for resection. There are criteria for transplant, Milan criteria. They are too strict, but it has been expanded. It's called UCSF or expanded Milan criteria for resection, for transplant. And the next treatment options is ablative therapies. Mostly they are thermal ablation plus irreversible poration, this IRE is called. So the drawback of these ablative therapies, mainly they are thermal ablation. They are the efficacy and toxicity depend upon the location of the lesion. That is important. If the tumor is near the luminal structures, subcapsular, subdiaphragmatic, or it is aborting vessels, then the efficacy may be low, toxicity may be high, they can be a heat sinking phenomena in those cases. Second important thing is the efficacy is also dependent on the size. On the right side, you can see a hazard ratio between the RFA versus SBRT. As the tumor size increases, the efficacy reduces in case of the ablative therapies. And if the lesion is not very well defined on ultrasound, then it's also a problem. And attaining a negative margin, like in surgery we say R0 resection, achieving a A0 margin is also sometimes dicey in case of ablative therapies. The lesions are slightly larger because it's a user dependent, and in case of RFA, the current may not actually be covering the whole, and it is a subjective thing. The other third treatment modality is arterial therapies, where the either a chemotherapy or blend beads or the radioactive material is inserted to the artery which is supplying the tumor, because liver has a dual supply and tumor is very actively, liver is receives from the hepatic artery supply. And then the other treatment modality which I will be talking today is SBRT. It is a very high dose of radiation delivered accurately, precisely in a very short duration of time, 3 to 5 days or 8 days, with minimum collateral damage, with some form of motion management is applied in case of liver and lung tumors. So this is SBRT. The advantage of SBRT is it is usually size independent. The efficacy doesn't vary so much from 3 to 4, 5, 6 centimeters tumors. It is independent of the location. We can fractionate, increase the number of fractions if they are very close to critical organs. There is a uniform coverage in contrast to the tear when there is a very hot within and periphery may not be fully covered. It is non-invasive, can be given in patients who are medically inoperable, risk adaptive fractionation is there, and it has been proven globally in case of lung tumors, brain SRS, vertebrae. The other important aspect when we are doing SBRT is it has got the immune component. It acts as the tumor acts as a in situ vaccine when we give SBRTs. It has been seen that according to different type of doses, you can have the immunomodulation from low dose to high dose ablative doses. So this, when we give a very high dose SBRT to a tumor, it increases the new antigen. That means it creates the tumor dead cell and make them as an antigen for the immune cells. So it is called, so it increases the tumor mutational burden. It activates the immune system so that immunotherapy can work better. It itself inside the immune system. So this was a cartoon published in Western Delhi when the first India's moon mission failed. So they were just laughing at the India's mission. So this was the situation of radiation almost 15-20 years back with respect to liver cancers. But now things have changed. This was so because the tolerances were not known, it was considered to be sensitive and all those things. So I will not be going in detail all those. So studies were done to find the tolerance of the liver, what is the adequate dose, all those things. So things have started changing. Now the SBRT is now a part of this club, the Hepatocellular Management Club. It is a part of this. So still there are few people who don't like it, like the BCLC group. And so in the most recent publication, they have not included SBRT as one of the treatment options, but most of the other groups, which I will be discussing subsequently, has included SBRT in part of the HCC management. This is a very nice editorial published by Laura Dawson in rebuttal to this previous 2022 BCLC exclusion. So I will be going to the stage-wise treatment management. So if the lesion is a single lesion, whether it is less than 3 centimeters, which falls into Barcelona O or A single lesion, then the treatment, if the liver is good, you can, and the features are not there for portal hypertension or cirrhosis, you can go for a resection. If there are features of like cirrhosis, other which fits into transplant criteria, then you go for transplant. And if there is BCLC-A with more than 1 lesion, up to 3 lesions, then again you don't go for, even the liver is normal, you don't go for resection, you go for transplant. And in the similar O and A, if it is not a candidate for transplant or surgery, then you go for ablative therapy. You mind that this is ablative therapy. And in BCLC-B, options are transplant versus the arterial therapy like TACE and TARE. And in C, PVDT or node positive, the systemic therapy is there after the immunotherapy and the bevacizumab. So where is the place of SBRT in this whole scenario? ESMO recommended SBRT, I have made a single slide where I have covered all those topics. So SBRT is recommended in ESMO 2021 guidelines, in the BCLC ONA. Indian guidelines by Puri et al. Published in 2019, it recommends SBRT in all the 3 settings. ASTRO recommends in all different settings where the SBRT fits. I will be discussing in a single slide all those things to avoid confusion. The American Association for Study on Liver Disease 2018, it recommends SBRT in T1, T2, and T3, which are medically inoperable. ISRS recent guidelines published around few months back recommend SBRT in early stage and more than 3 centimeters. And even the NCCN, this is the latest NCCN, which recommends in operable as well as inoperable cases of SCC, the role of SBRT. So this was my original slide where I have mentioned all the different treatments according to the stages. So if you see the ASLD, ESMO, ASTRO and ISRS, they all recommend the use of SBRT if it is medically inoperable in BCLC O and A. Not be going into details, but they all recommend it. If you go to BCLC-B, American guidelines, ASTRO guideline, ISRS, ASTRO and Puri guidelines, they also recommend use of SBRT in these settings. And also in case of PVDT, it is recommended by the ASTRO recent guidelines and the Puri Indian guidelines. So you can see that SBRT can fit in all stages of HCC. That is important. That is important to take home message, that the SBRT is effective. I will not be going to too much of literature, but few important literatures. In case of early stage, these are prospective phase 1, phase 2 studies where there is a local control of SBRT in HCC to the tune of around 80 to 95%. This is equal or better than the RFA and TACE at any point of time. This is from Michigan University. In case of early stage, they have compared SBRT versus RFA. The blue is the SBRT curve. You can see the difference in SBRT versus the RFA. And mind that all these patients who are SBRT patients, they were enriched with adverse features. That means they have poor liver function tests, they were recurrent after, they were post-TACE failures. So poor patients, still the outcome is better in case of SBRT as compared to RFA in early disease. This is ISRS meta-analysis and systematic review in localized SCC. 17 studies, almost 1,900 patients, 5-year local control with SBRT 82%. 5-year local control 82%, that's a big number. And it has been seen that there is an impact of size also. And at the same time you see the local control of RFA and resection are to the tune of 70 to 90%. So no way it is inferior to RFA or resection. Now, in early stage, as a bridge therapy, we offer bridge when the transplant waiting time is more than 6 months. So this is a Toronto study which have compared SBR in case of early stage who were awaiting transplant because of the long waiting list. They compared SBRT versus TACE versus RFA. The dropout rate, that means who were not eligible for, once they were in the waiting list, they fall out of the transplant list. That means the dropout list was same in all the 3 categories, whether SBRT, TACE or RFA. You see the 5-year survival from the treatment, from the time of transplant, it is almost same. Numerically, it is slightly better than SBRT, but statistically, it is same. This is a prospective study which is comparing SBRT versus TACE versus HIFU. This is from Korea. This is from Seoul University, Korea. So this is compared at different time points: 3 months, 6 months, 9 months, 12 months. You see the response rate. At any time point, the SBRT response rate was much better than TACE or HIFU. And the dropout rate was least in case of SBRT as compared to two modalities. This is a prospective data published in the Hepatology Journal. Now, the other domain, the downstaging, that means tumors which are outside transplant criteria, but still, because of their size, can they be downstaged? So this is normally followed in intermediate stage. So there are different downstaging criteria. This is a meta-analysis, but they did not mention SBRT in this because they were not applying SBRT. So, but there are recent some papers which are saying that if you do SBRT in patients for downstaging, it is also effective to the tune of 79 to 87%. There are the first is a prospective study. Now coming on to this cell-based setting, that means after TACE, in initial stages, like when you apply TACE, there are recurrences. Then when you, what is the role of SBRT? This is a bridge study which shows that after TACE, the local failure rate are to the tune of 55 to 77%. So see the failure rate of, this is a prospective study, bridge study, 77% failure rate after the TACE, which is a radical treatment considered according to BCLC. So this is a retrospective study which is looking at post-TACE SBRT, the local control rates 3 years 91%, OS at 3 years 72%. And this is again a prospective study. It was closed prematurely because of COVID and other reasons. So this study compared post-TACE failure, either re-TACE or SBRT. And they have shown that the local control with SBRT as compared to TACE was much superior. You can see the graph there, p-value 0.0002. Progression-free survival are also much better in SBRT as compared to TACE, re-TACE. So this is not directly TACE, re-TACE. So prospective study, we have almost around 40-45 patients. The data is there. This is combination of TACE plus SBRT versus SBRT alone. TACE, that means combination of both these modalities, as I was discussing with Dr. Deepti also. So when we combine these two modalities together, the effect is much more. And there is an OS benefit. You can see the diamond towards the combined treatment modality. Now coming to the role of SBRT in portal vein tumor thrombus. Earlier, portal vein tumor thrombus used to be considered as a gone case. There are different ways of classification of portal vein tumor thrombus. It starts from VP1 when it is subsegmental, VP4 main portal vein. So studies have seen that if you do a transplant in portal vein tumor thrombus, it is a disaster. There is a very high risk of local regional as well as systemic recurrence. So it is not usually done. And but it gives a small window where you can downstage the portal vein tumor thrombus and it opens the path of a transplant. In such cases, it has been seen that it might work. And the aim when we treat a portal vein tumor thrombus is to sterilize the thrombus or recanalize. Sterilization is more important than recanalization. The TACE is not done in case of the PVDT because there is a risk of necrosis. So this is a meta-analysis which is looking at the different modalities in case of SCC and portal vein tumor thrombus. The pooled response rate, 51% response rate with normal radiation, 33% with TARE and 70% with SBRT. We have a publication from Medanta. This is published in Transplantation. We have looked into the rate of conversion of post SBRT to the portal vein tumor thrombus, and that means downstaging and doing the transplant. So there were 51% progression recurrence-free survival with SBRT, downstaging and transplant as compared to when it was not done. We also looked into the response rate. The response rate was to the tune of, that means in SCC and PVDT, response rate was 58%. And 29% patients which were written off, they were amenable for transplant. They underwent transplant. So this is one of the case. You can see the portal vein is not seen on left side, on right side is totally opened up after doing the SBRT. And this is one paper on left side in case of advanced HCC by Dr. Deepti. And they have shown that SBRT is even feasible in Barcelona type C, when there is a PVDT, metastasis, or node positive. And this is the RTOG trial 1112, which have shown that SBRT is doable, feasible, improved survival in case of advanced disease also. Dose fractionation, just few slides, these are technical. Now there is a sufficient evidence that we need BED more than 100. Even the NCCN understand this fact. This is the very recent NCCN 2024, where they have, you can see, they have cut the 30 to 50 gray, they have escalated dose to 40 to 60 gray, 3 to 5 fractions. The beauty of SBRT is we can reduce the toxicity, at the same time maintain the efficacy by increasing the number of fractions. These are the guidelines. I will not be going into detail like what doses to be given. This is for radiation oncologists. And we are participating one of the trials, there is IEA trial, which is comparing SBRT versus TACE. This is an international randomized multicentric trial. And SBRT is safe. You can see very low toxicity, acute and late toxicity. The technical requirement for SBRT is they should have, since we are treating the liver, which is a moving organ, we have to freeze the motion, either by a breath hold technique or by tracking. On right side, there is a fiducial placement, gold marker placement in the liver, and then you track with the robot. Left hand side is a breath hold treatment, right side is a CyberKnife based tracking treatment. That means the patient will take a breath, the robot is going to track the tumor. MR is something new which has come up, and it improves the surety that we are hitting at the right place. We can escalate the dose, we can improve the outcome, we can reduce the toxicity. Important thing is post SBRT, the assessment of response is challenge and need patience, in contrast to when we are doing TACE, because in TACE you can see the response in case of total necrosis at 4 to 6 weeks. In SBRT we have to have patience. For example, in this patient there is a zone of hyperemia after the SBRT at 3 months, which subsequently subside. One of the other patient you can see, this is not SCC but cholangiocarcinoma metastasis, large metastasis, and 1.5 years you can see just after the SBRT it has gone. You can see very beautifully the intermediate dose was forming. So this is the beauty of SBRT. This is one of the case of HCC, early HCC, pre and post SBRT. A very beautiful. This is a mixed HCC plus cholangiocarcinoma. Post SBRT you can see the 1 year, 6 month and 1 year response. Is it possible with TACE? No, I don't think so. So my last slide, the take-home message, SBRT gives an excellent local control, is a very excellent modality for local control. It's non-inferior to other non-surgical modalities like RFA, TACE or TEER, maybe in fact superior, effective in whole spectrum as HCC, as you can see. So very important thing, read, we always dare to treat. Intelligently, you document whatever you are doing very meticulously, you discuss the results with your other department colleagues, and you collaborate. So SBRT is like a sharp knife, used judiciously and consciously. Thank you, and this is our team at Medanta, and we are organizing a Brachy conference 2024, so everybody is invited. Thank you.
Thank you, Dr. Shambish sir, for your exceptional presentation. We are grateful to have you, to have an opportunity to learn from you. Ladies and gentlemen, now I would like the chairpersons to present a token of appreciation to our esteemed speaker, Dr. Shambish. As we conclude this intellectually stimulating day, I would like you to invite you for dinner. Thank you for your presence and let us embark this journey forwarding towards advancing cancer care through knowledge and